Good morning, everyone, and we are going to start our Remifentanil Symposium. Now, Remifentanil is going to be launched in India, and there's a lot of interest in how people are going to use Remifentanil in day-to-day practice. So we will start off with pharmacology of Remifentanil, why it's so unique. I'll be giving this lecture, and then we got Remifentanil as alternative muscle relaxants for intubation and ventilation, which Dr. Achal there will be talking about. Dr. Katirvel will be talking about Remifentanil in cardiac and vascular anesthesia. Jody from Canada will be talking about it in use in pediatric anesthesia. And then we have a team from UAE with Nitin Manohara talking about Remifentanil in neuro-anesthesia and monitoring. And then we'll also have a small panel discussion. Dr. Achal, as you all know, he is director of liver transplant anesthesia, and is also professor at London Health Science Centre in University of Western Ontario in Canada. His main interests are liver transplant anesthesia and coagulation, cardiac anesthesia and TTE or TEE, medical education, and he loves travel and photography. Then we have Katirvel, who is professor director of perioperative echocardiography education and training at the Cleveland Clinic Cardiac Anesthesiology Fellowship. He's done his undergraduate from Coimbatore Medical College, and he did his residency from Beth Israel Deaconess Medical Center, Harvard Medical School of Anesthesia. His special interests are cardiac anesthesia and TEE. Then we have Katirvel. You all know him from our Pediatric Symposium. He's top pediatric anesthesiologist at the Hospital for Sick Children. He's also assistant professor of anesthesia at University of Toronto. He's also director of pediatric anesthesia fellowship program at the Hospital for Sick Children. And his special interests are regional anesthesia, pediatric anesthesia, and creation of entrustable professional activities and competency-based training and accreditation in pediatric anesthesia. For our neuro part of it, we have Nitin, who is associate staff physician anesthesiologist at Anesthesia Institute, Cleveland Clinic, Abu Dhabi. And a special interest on neuroanesthesia, neuromonitoring, awake craniotomies, neurocritical care. And he'll be supported by Mukilan, who is also an associate staff physician at the same hospital, that's Cleveland Clinic, Abu Dhabi. And his interests are also neuroanesthesia, neurocritical care. And Vinay Bhairappa, again, another of the Cleveland Clinic, Abu Dhabi, associate staff physician. He's also clinical associate professor in anesthesiology there. And he also has special interest in neuroanesthesia, anesthesiology for interventional radiology, outcomes in anesthesia, safety, neuroanesthesia, and neuromonitoring. And with that, I think I will start off with my lecture, and others will soon be joining us. So I'll be talking about Remifentanil and why is it so different from other opioids. I work as a consultant anesthetist at University Hospital Liverpool. I'm chairman of theaters and anesthesia, and I'm also lead for specialty audit and improvement, regional anesthesia lead, and clinical governance lead. And my main interests are regional anesthesia, trauma and vascular anesthesia, education training, and audit and improvement. I have nothing to declare, and some of the drugs which are actually shown in the images we use in our hospital, I have no interest in any kind of financial involvement with that. So here we go, Remi study go. So that's remifentanil molecule. And how is so different from our other molecules, which belong to the enaldopaparin group? That is your fentanyl, alfentanil, sufentanil. So you can look at it in the box that is a common structure. That's a piperidine group. But what we have in remifentanil is the ester group, and that makes us more interesting. It belongs to a group of drugs which are called soft drugs. So what are the soft drugs? Asmolol comes in the same group. Remizolam, which has been recently launched, and clavidapine, they all belong to the soft drug. These are drugs which have predictable and controllable metabolism. Once they have achieved their therapeutic role, they are metabolized to non-toxic moieties, which are then excreted by the kidneys. So they have a rapid onset of action. So as you increase the dose, the predictable blood concentration increases exponentially, or rather, at least it's actually linearly rather than exponentially. And if you look at the remifentanil, we're looking at the infusion rate. If you give an infusion of 0.1 microgram per kg per minute, we can have a steady concentration, blood concentration of around 2.6 nanogram per ml. And they have a rapid offset. So if you look at remifentanil, once we switch it off, irrespective of the duration of infusion, it could be 2 hours, 3 hours, 8 hours. The remifentanil drops to 50% of its plasma concentration within 3 to 10 minutes. So that's why it says the context-sensitive half-life of remifentanil is around 3 to 6 minutes at the most. And this happens because the ester group, which is there in remifentanil, it helps metabolizing the drug rapidly by the non-specific esterases, which are present in the blood and plasma. Now, this is not the plasma cholinesterase, which metabolizes hexamethonium. And it is metabolized to remifentanil acid, which is inactive compound and which is excreted through the kidneys. So high clearance, that is, which is defined as the amount of plasma cleared of the drug per minute, is around 40 mL per minute per kg. And it has smaller volume of distribution, and this leads to short elimination half-life of for remifentanil 3 to 10 minutes, and we'll show you a comparison to other drugs. So this is a comparison of the piperidine group of drugs. So look at remifentanil, alfentanil, fentanyl, sufentanil. Now, if you look at the clearance for remifentanil, it is 40 to 60 ml per minute per kg. That means there's a large amount of plasma cleared of the drug very, very quickly. Whereas for fentanyl, it's only 20, 10 to 15 for sufentanil, and alfentanil it is 3 to 8. So the quickest one which is cleared is remifentanil, then comes fentanyl, followed by sufentanil and alfentanil. And hence the terminal elimination half-life for remifentanil is around 9 minutes. And for alfentanil is 90 minutes, fentanyl 260 minutes, and 150 minutes for the sufentanil. And because remifentanil is metabolized by the plasma non-specific esterases, the context-sensitive half-life, even after 3 hours or 8 hours, is only 3 minutes for them, compared to fentanyl, which is more than 100 minutes, and alfentanil 50 to 55 minutes. So the drug itself, let's look at the drug. So it comes as 1 milligram, 2 milligrams, and 5 milligrams. We tend to actually in our hospital have 2 milligram and 5 milligram bottles. And there are different companies which are making this drugs. Like I said, we don't decide on this. Whatever comes to us, we use them. Recently, there was shortage of remifentanil, but it's okay now, I think. And if you look at the vial, it is a powder form, lyophilized powder form, and we have to reconstitute this with water. So you make it, so you got 2 milligrams to add 2 milligrams, 2 mLs of water to it, or 5 milligrams, you add 5 mLs of water, and have a concentration of 1 milligram per ml. And this can then be diluted further. The commonest dilution which used for target control infusion or TCI is around 50 microgram per ml. So it's easy to just take 5 milligrams and put it into a 100 ml saline bag, and you get 50 microgram per ml, and just draw it up in a 50 ml syringes. So the bottle not only contains remifentanil, but it also contains glycine. And it's got acid hydrochloric acid, which makes the pH around 4.5. And pK is 7.07, so it is closer to, is less than the physiological pH on the blood, that is 7.4, and hence a lot of its non-ionized form is present in the blood. The fact that this contains glycine, which is an inhibitory transmitter in the nervous system, it is contraindicated for spinal or epidural. So remifentanil should not be used for spinal or epidural or caudal. Coming to what the drug does to the body, that is the pharmacodynamics of remifentanil. As the dose increases, so does its effects. Then we all know what the effects of opioids are on the body. The only advantage, greatest advantage remifentanil has, that it does have rapid onset, and the context-sensitive half-life is only 3 to 6 minutes. And I've already explained why that is. And those who do not understand what context-sensitive half-life is that blood concentration decreases by 50%, irrespective of the duration of infusion. So looking at the cardiovascular effects of the remifentanil. So if we give an infusion of, say, 2 microgram per kg, okay, that probably is high dose. Say we give over 1 minute, and within 3 to 2 minutes, you'll see heart rate and blood pressure drop. And these are dose dependent. So higher the dose you use, greater is the effect on heart rate and blood pressure. So bradycardia is not uncommon with remifentanil when you give a rapid infusion. But there is a ceiling effect on this. So if you were to have infusion greater than 2 micrograms per kg, and even if you increase it up to 30 micrograms per kg, there's no further drop in the blood pressure or heart rate. So there's a ceiling effect you see with remifentanil. What about its effects on the respiratory system? Now, again, these are dose dependent. So we get dose dependent reduction in the respiratory rate. So there'll be depression in the respiratory rate. There'll be depression. There'll be reduction in the volume, volumes. But because it is shorter acting, once you stop it, the recovery occurs. So compared to other opioids, spontaneous respiration tends to occur at the dose or the plasma concentration of 4 to 5 nanogram per ml plasma concentration. So from the graph, you can actually see these are comparing the alfentanil and remifentanil. And as you increase the dose, there is depression in the respiratory rate, and it continues, so it's maintained as infusion maintained. But once you stop it, if you see the red circle, that is for the remifentanil, it tend to recover, the respiratory tend to recover much faster than alfentanil. And that's because it is metabolized a lot more quickly, and the effect plasma concentration drops very, very quickly. This is an interesting one. What is the effect of remifentanil on musculoskeletal system? Now, if you were to give a rapid infusion that is more than 0.1 microgram per kg per minute, which would equate to around 2 to 2.5 nanogram per ml of plasma concentration, or you give a bolus of greater than 1 microgram per kg, or if you give bolus, so you already have infusion going, and then you actually decide to give a bolus of remifentanil, then you can expect the decrease in the compliance. So the patient's chest will become rigid. It will go, this is called wooden chest syndrome. And this is seen with any of the opioids given in a higher doses. But if you are concurrently, you are actually administering hypnotics like propofol, and you are using neuromuscular blockers, then you don't tend to see this. And if this seems to happen on a GA for whatever reason, the first thing you can do is either reduce the concentration or discontinue it completely. And if the patient is spontaneously breathing, you can actually give an MDR. And still, if you do not actually get any response, we had this in one of my consultant colleagues who, instead of using the Minto model for the remifentanil, was using the propofol model, and they gave a large bolus and patient went with that. So you need to actually just wait, and and you can even give naloxone to reverse the effect of remifentanil. Just like any opioids, you can reverse the effect of remifentanil as well. What about histamine release? It's seen that there's no histamine release even when you give very high doses of 30 microgram per kg. There is no histamine release. So the hypertension is not an effect of histamine. It is the effect of sympatholysis and also vagotonic effect of remifentanil, which causes hypertension. It's not histamine release. The effect on the cerebrovascular system, if you're using infusion of 0.5 or to 1 microgram per kg. Now, if you look at the anesthesia where you have used nitazoxanide and isoflurane, maintaining the PCO to around 30 millimeters of mercury and around, there is no effect on the ICP, but because of the direct effect of the vagotonic effect and the sympatholytic effect, there is reduction in mean arterial pressure and hence reduction in the cerebral perfusion pressure. If we're just using nitazoxanide anesthesia, cerebral vascular reactivity to carbon dioxide is maintained. Okay. Now, what about the effect on the EEG? Infusions of anywhere from 0.1 to 8 microgram per kg per minute. There is no epileptic form activity on EEG, so it can be used. It has been used, in ECT, so you can use it for ECT. Rather, it is very useful. It tends to maintain the electrogenic activity. What about the effects on kidney? So yes, it can be used even in patients who have end-stage renal dysfunction, where the creatinine clearance is less than 10 ml per minute. And ventricular response to hypercarbia is unaltered. The metabolite, the remifentanilic acid, is excreted through the kidneys, but because it's non-toxic, it is not potent at all. It doesn't affect any of the systems. Again, in liver, even with severe hepatic dysfunction, when patients are awaiting liver transplants, the ventilatory response to hypercarbia is unaltered, so it cannot be used in both patients with kidney and liver disease without any issues. In ophthalmic procedures, it does not affect the intraocular pressure, and so it's again safe to use in ophthalmic surgery. Now, what about the effect of aging? So EC50 for remifentanil, that is seen by development of delta waves on EEG, it increases with age. And that's why for patients for more than 65 years, as compared to younger patients. We need to reduce the dosage by 50% in patients who are more than 65 years old. Male, female, there is no difference in the dosing. You can use it either way. Now, this is broken down by non-specific esterases. This is different from pseudocholinesterase or butyrylcholinesterase. And so duration of succinylcholine is unaffected by the use of remifentanil. It's broken down as it would normally be in any patient. So remifentanil does not affect the duration of succinylcholine. So anesthesia, what is the effect of remifentanil on anesthesia? So remifentanil has got synergistic activity with hypnotic, that is propofol, orthohypnotones, the volatiles, and benzodiazepines. Rather, it is said that when you're using remifentanil, it's better to actually use these agents. Even if it's using for sedation, it's better to combine it with benzodiazepines, give around 2 milligrams of midazolam, and then you don't need to use larger doses and you don't see the side effects of remifentanil. So effect on analgesia. So if you're giving an infusion of 0.05 or 0.1 microgram per kg per minute, this equates to plasma concentration of 1 to 3 nanogram per ml. And if you actually look at some of the TCI pumps, when you switch them on, if you switch on to remifentanil, usually starts around 3 nanogram per ml. So I think that is a factory preset for it. And with this concentration, you get analgesia with minimal respiratory depression. But if you use a infusion at 0.2 microgram per kg per minute, which equates to plasma concentration of 5 nanograms per ml, you can get reversible respiratory depression, and you can notice some amount of muscle rigidity. It may not be wooden chest syndrome. You can still notice some amount of peripheral muscle rigidity can be seen at these concentrations. So what does body does to the drugs? This is the pharmacokinetics of remifentanil, and I've already explained to you is that remifentanil is rapidly eliminated. If you look at it's got a looking at 3-compartment model. It's got a rapid distribution half-life of 1 minute and slow distribution half-life only 6 minutes. And its terminal half-life is only 10 to 20 minutes. So the effective biological half-life is just 3 to 10 minutes. So irrespective of the amount or the duration of the infusion, once you stop at 50%, reduction in the plasma concentration occurs within 3 to 6 minutes. So there's a short half-life. So once you give the drug IV, it's get rapidly distributed to blood and well-perfused tissues, and the distribution of 100 ml per kg. The steady state volume of distribution in the peripheral tissues around 350 ml per kg. And 70% of this is protein bound, and 2/3 of them occurs with alpha-1 acid glycoprotein. So are there any adverse effects of remifentanil? Of course, there are. And we've seen that there are dose dependent. You will see respiratory depression as you increase the doses. If you go above 3 nanogram per ml plasma concentration, the post of nausea and vomiting is no different from any of the opioids. So just because you give infusion, it is rapidly metabolized, does not mean patient can't have nausea and vomiting. They do have pruritus even at lower concentration. Muscle rigidity is seen at higher concentration. It is vagotonic, it is sympatholytic, hence bradycardia is seen. But also you can actually see tachycardia with ineffective dose. And also towards the end when you tend to stop, and if the patient has not got alternative analgesia, I'll talk about it in a minute, you can actually have patient tachycardia and hypertension. So what about the doses we use? Now, let's look at the induction of anesthesia, and you're using for intubation. Then you can use a dose of 0.5 to 1 microgram per kg per minute infusion. If you're using with nitrous oxide, acetylene, you can use 0. To 0.25. With propofol, again 0. So it is commonly used as a total intravenous analgesia along with propofol infusion. And you can continue the infusion in the postoperative period for analgesia. And the reason for it, we will actually talk about it. And the use of, if you're using remifentanil for analgesia, which Dr. Achal will actually talk about how it is used for intubation and using it as sole agent for intubation instead of non-deployable muscle relaxants. So use of concomitant use of thiopentone, propofol, voltal, or midazolam, we can reduce the dose by almost 75%. So for induction, we use infusion of 0.1 microgram per kg per minute. And this is important if you're not using TCI models. And or you can use 1 microgram per kg over 30 seconds as a bolus. We're using a bolus along with a bolus. So you can use bolus and infusion. I tend to actually start a patient on infusion of 3 nanogram per ml infusion. And if I have to then do an intubation without neuromuscular blockade, then I would actually give a bolus along with propofol with that. Maintenance is 0.05 to 2 microgram per kg per minute. Okay. And if you want to leave patients spontaneously breathing, then you need to make sure that you are using a very low dose. So you're using 0.04 to 0.01 or 0.025 nanogram per kg per minute, microgram per kg per minute, or 10 to 25 nanogram per kg per minute infusion. So higher the dose, the greater the chance of respiratory depression. But if you remain around 3 nanogram per ml, TCI, that is target control infusion, then you can have patients who will stop breathing, but they will follow your command. You can actually ask them to start breathing. It's always better to start with an infusion, slow infusion, rather than use boluses in patients who we want to keep spontaneously breathing. For monitor anesthesia care, this is the one I was talking about. If you give single dose, give it over 90 seconds. And you can use 1 microgram per kg over 30 to 90 seconds. But along with 2 milligrams of midazolam, you can reduce the dose. So you can nearly half it to 0.5 microgram per kg. And with continuous infusion, if you are going to do say, for example, you're going to use it for giving a block. It's been used for giving eye blocks, for your peripheral nerve blocks. Or in that case, use the infusion 5 minutes before you start thinking of actually doing a block. And if you're using remifentanil, use 0.1 microgram per kg per minute. But if you're given midazolam, then use 0.05 microgram per kg per minute. So just half the dose you have to use. And then you can continue the infusion as well if you like. This is a good table in which, they were given up to 2 microgram per kg, but you never need to use till there. You can just be up to 0.1 microgram. Which gives you around plasma concentration of 2 to 2.5 nanogram per ml. And this is given according to the weight. So if you want to use, say, 0.5, then for a patient who is 100 kg, you need to use 6 ml per hour. And this is a concentration we used around 50 microgram per ml. That's the usual concentration we tend to maintain. I'm just going to show you a video how we use it with So this is the video of setting up the TCI model. So we go into Minto model, you select remifentanil, and the concentration we use syringe is 50 microgram per ml. You can see there's a label that's 50 microgram per ml of the remifentanil syringe. You okay it. And then you have to enter the age, the weight, the height, the gender. Even though gender doesn't actually matter in most of them, but I think it becomes very important when you're looking at obese patients where the fat distribution is different. In those cases, you need to select the ideal body weight, not the actual body weight, but ideal body weight should be selected for obese patients. And then you do the target plasma concentration. Say I'm going to set it to the highest. So I'm going to use it to 6 nanogram per ml. And you can see that it's changing the bolus. So it's going to give 115 microgram bolus. And let's see how rapidly concentration actually builds up. So you will see that how the plasma concentration is building up. The effective concentration is obviously lagging behind the plasma concentration, but it will slowly pick up very, very quickly. So just because the volume of distribution of remifentanil is small, and it will build, the plasma concentration will build up very, very quickly. It does not get redistributed like other agents which redistribute. It does not redistribute as much. And hence the buildup of the plasma concentration is very, very quick with that. So it's been only few minutes, not even a minute or so. And it's already going up to almost 5 nanogram per ml. And with no time, it will actually reach the 6 nanogram per ml. That is the effective concentration I'm looking at. And on the lower, you can see that it's not infusing. It's just giving a bolus dose slowly. And I will show you in a graphic form in a minute when you can actually see how quickly this is delivered. You need to be careful with this kind of dose. So if you go at 6 nanogram, and this is an awake patient, you not use any midazolam, you not use propofol, you will likely get patients complaining of tightness of chest. They will stop breathing, and they might have other side effects. So be careful when you are using such high concentrations of remifentanil. So it has reached 6 nanogram per ml. The plasma concentration is dropping because it stopped infusing at this minute, and it'll go on to a continuous infusion to maintain that concentration set. So I'm going to just show you in a minute the graphic form. You can actually go on a graphic form in a minute. I was going to press that now. Okay, let's see. That's the graph. So you see the rapid, bolus, and that's over the time. Okay, that is the concentration of buildup, and now it will start infusing to maintain. So it's now giving at 0.2 microgram per ml. So I was talking about, so I had said that 0.1 microgram per kg per minute equates to around 2 to 2.5 nanogram per ml, whereas 0.2 microgram per kg per minute will equate to almost 5 to 6 nanogram per ml. Now reduce the dose to 4 nanogram per ml because that's a pretty high dose, and it's stopped infusing. And this is, you can see that how quickly the plasma concentration is dropping. So you can see the CP is dropping much more quickly than the effective concentration in the plasma. So it stopped infusing completely till the you reach the set plasma concentration. That's the graphic form. It's trying to actually drop that. So if you actually stop it, it will within 3 minutes it will actually come down to the baseline of 50% reduction in plasma concentration. So the plasma concentration already below 4 nanogram per ml. That's trying to reach the concentration. Still not there. Let's go back on the effective concentration with time. Okay, that's there. So we're still around, effective plasma concentration is 5.4, is rapidly dropping. And that's what we're saying, that because the on stoppage of the infusion, which this is doing, the non-specific esterases are metabolizing the remifentanil into inactive metabolites. And because it's not redistributed, there is no gradient between the tissues and the plasma concentration. So plasma concentration will also drop pretty quickly to the set concentration. So it's now nearly getting there. And as soon as it reaches the 4 nanogram per ml, it will start infusing at a lower rate. I'm assuming it will go around 0.125 microgram per kg per minute. Let's see how we're doing. Still 0. Okay. We're nearly reaching there 4 nanogram per ml. And they can see on the top, it's Minto model. The concentration is 50 microgram per ml. So there's 4.36. So long the contact sensitive half-life is around 3 minutes. So to drop to 50% of the concentration, this is not 50%. We're only going from 6 to 4 nanogram per ml. So it should take less than a minute or a minute or so, and that's nearly reached there. And you can see now it is going. Like I said, it was 0.16, so 0.15. So it is 0.16 microgram per kg per minute. That is the infusion rate, depending on the body weight. So pretty close. So it's easy to use. So if you don't have the TCI pump, but you have normal pumps, you can still use it according to kg body weight per minute, and you'll be pretty accurate. And I would actually ask people to actually remember the dose as 0.1 microgram per kg. So the analgesia offset is also quick, and this can lead to withdrawal hyperalgesia. That means you need to start loading a patient with the longer-acting opioids before you switch off the infusion. Or if you got epidural or local anesthesia infusion, you make sure that the patient actually get that. So to summarize, remifentanil is a clinical versatile opioid. It produces intense opioid effects. So it is very, very intense analgesia. And because of its unique pharmacokinetic profile, it is highly titratable, and the effect is dissipated very, very quickly, which enables a predictable wake-up even after prolonged infusion, because of contact-sensitive half-life is 3 minutes, 3 to 6 minutes. And it has favorable pharmacodynamic characteristics irrespective of the age. So less than 65 years, patient with renal or hepatic dysfunction, you can use a similar kind of doses. And it fulfills the 5 requirements for any drug which necessitate to be a rate-controlled delivery system. It's got a short elimination half-life, no active metabolites, is offset by metabolism or excretion or redistribution, and concentration effect relationship is constant. And it's got a narrow therapeutic index, so you need to be careful with that. So make sure you don't overdose. So how do you, convert now microgram per kg to nanogram per ml? And this is very easy. So as I was saying, 0.1 microgram per kg per minute equates to 2 to 2.5 nanogram per ml. And any increment increase in 0.25 will increase concentration by the same amount. So for example, if you increase from 0.1 to 0.2 microgram per kg a minute, it will increase to almost the double. Okay? And I've shown you on the TCI how it is. And thank you for listening. And I will take questions and before we go on to the next lecture. Dr. Achal and Dr. Jody, Dr. Emma, everybody welcome.
Thank you, Shiv. Good morning or good afternoon.
Good morning. Good morning. Sorry, I think there was some confusion with the time, but I think I should have started at midday, but I think there was confusion. I had to wake you up on a Sunday very early. Sorry about that. So, is there any comments or any thing which people want to add? Shanli, welcome.
Thank you, Shiv. Thank you.
Anything which you want to add? I try to actually keep it very precise about the pharmacology. People don't like pharmacology, so I try to actually keep it very precise.
No, actually, it was very understandable. So I think it was very nice.
Thank you.
Yeah, it was very crisp and clear.
Thank you. I will obviously this is there on the YouTube, so people can listen to anytime. I mean, my worry is that it's been introduced in India now, and people will not actually have TCI pumps, but they have normal pumps. And it's such a predictable drug that you can actually use a known concentration. If you know body weight, you can convert kg body weight per minute as for infusion, and it's very, very predictable. So that table actually will be useful.
Yeah.
So I think let's move. I have already introduced you guys. I already had a PowerPoint presentation, so I have introduced your faculty, but you can also give your own brief introduction. So we all move on to the next talk, which will be about remifentanil as alternative to muscle relaxants for intubation and ventilation. And this will be Dr. Achal. There will be talking about this. Over to you, Dr. Achal.
Can you see my slides now, Shiv?
Yes, they are visible and you're clear. You're
Okay. Thank you so much. Shiv very nicely and crisply discussed about the pharmacokinetics, pharmacodynamics, and pharmacology of this very new ultra short acting drug. And I'm just going to stick to just the practical aspects and give you my personal experience. I'm not going to talk much about the theoretical part of it. So when I was in England in mid-90s and I saw this drug being introduced initially as a multi-center clinical trial before it was introduced. And it was used in cardiac because I was in cardiac, and it caused severe hypotension and bradycardia, and it was taken out immediately. The trial was stopped. Move forward another 5-10 years, it became so popular in other fields that it's kind of come back slowly in cardiac as well. But I'm going to talk about just the alternative to muscle relaxants for intubation and for ventilation. This is my place of work. I'm a professor of anesthesia at London Health Sciences Centre in Canada, Ontario. And I have been using this drug since 2003, so almost more than 20 years. And I will just highlight again some very important practical points, which Dr. Shiv has already mentioned. Remifentanil is a very powerful ultra-short-acting narcotic and does not need liver or kidney for its metabolism. Its context-sensitive half-life is 5 to 6 minutes. That means that if you're giving this infusion for, say, 5 minutes, or you're giving it for 5 hours, once you stop, it will be clear from the system within 5 to 7 minutes. So it is quite predictable. Since it is a very powerful narcotic, it of course causes respiratory depression and apnea. So whenever you are using it, always have bag mask ventilation and airway devices for intubation or otherwise immediately available. So this is one drug which I would not suggest that you take the pump onto the ward and you're doing some minor procedure without any backup of bag mask or any artificial airway devices. So have to be careful. It also causes significant hemodynamic changes, which is almost always hypertension and bradycardia. And because of the vagal stimulation and sympatholysis action. So you should always keep vasoactive drugs very close by. If there is bradycardia, you should have glycopyrrolate readily available, or atropine, and with hypertension, have phenylephrine or something available. And I know people have been using remifentanil without anything, but I have started using remifentanil infusion mixing with phenylephrine infusion. The end concentration of both in a syringe is 50 microgram per minute, per cc of that solution. So it can be used as a bolus dose between 1 to 4 microgram per kilo, and as an infusion, as Dr. Shiv mentioned, between 0.02 to 0.2 mics per kilo per minute. And I'm sorry, we are here in the university hospital, but we do not have any TCI pumps. So we use our regular infusion pumps for this. So we just go by microgram per kilo per minute basis. So for monitored anesthesia care, I usually give from 0.0 to 0.1 mics per kilo per minute. After that, I'm a little concerned about it might be causing apnea or something, other side effects. If I'm using it for GA, for maintenance, then I usually give 0.08 to 0.2 mics per kilo per minute. And roughly that equates to the MAC concentration of 0.5 to 0.6. What does that mean? That means when you're giving remifentanil infusion at 0.1 or 0.15 mics per kilo per minute, the vapors you have to give is maybe just 0.6 or 0.7 max. You don't have to go up to 1 or 1.2 max. So another very important thing, you need to have a well-running IV and a reliable delivery system. It cannot be given diluted in a bag and with a drip chamber. So I would suggest that you should always have a very reliable delivery system as an infusion pump. I'm talking about a well-running IV. If you are connecting your Remi infusion at this port and somehow the bag is finished and IV is stopped working, this infusion pump will slowly keep filling up this column of the IV tubing. And then you suddenly realize, oh geez, and patient will probably start waking up or will have tachycardia or something. And by the time you realize you change the IV fluid bag and then give a bolus, then this column of IV, which is not totally concentrated remifentanil, will go in and you will have some very drastic side effects. So I would like to suggest that you use it at the infusion very close to the patient as possible so that you can remove this particular issue. However, if you are vigilant enough, then of course you can, this is what we use here. We don't have this kind of IV cannula. So this is our infusion pump, very simple. So it tells you Remi, and I've set it at 50 mics per cc, and my dose rate usually is 0.15 microgram per kilo per minute. And then you put the patient's weight and the dose you require. So how did I started using intubation with remifentanil? This is like an interesting story. In 2012, there was a Canada-wide shortage of rocuronium. In fact, there was a North America-wide shortage. The manufacturers at that time, I think, was Organon, I'm not sure. But even in the US and Canada, the drug was in a very short supply. So there was frequent emails from our administrators, from our chairman, that not to use rocuronium, which had been the standard of choice for our practical purposes. And they asked us to use only for special circumstances where you cannot use the alternatives. And the alternatives were succinylcholine or cisatracurium. So yes, of course, we do succinylcholine for intubation, for rapid sequence, for difficult airway, anticipated RNA. So we use succinylcholine for sure. And cisatracurium may not be a great agent for intubation purposes. Of course, we can use it, but I have seen if you use it for intubation for high dose, it is a little bit longer acting and it might cause some histamine release. Anyway, we can use it, but I had this opportunity to try something different, and which was not a research project, just to try out a different option. And I did some literature search, and I knew it beforehand also that this one particular paper struck me. And the authors had used remifentanil bolus along with propofol for intubation. And what they found, their main thing was that the ED95 for intubation was 4 microgram per kilo as a bolus. But of course, this was also associated with significant drop in heart rate and mean arterial pressure, which was understandable. So 4 microgram per kilo, then I started using this particular dose after propofol infusion, and I have been intubating. So I'll try to tell you my recipe for that. So you have to be very careful about calculating the doses of this very powerful drug. So the preparation may be slightly time consuming because you have to make sure that you are giving the right dose. So this, again, Remi intubation is useful in situations where you want to avoid muscle relaxant altogether, and you're not using it just for intubation. And after that, you might resort to cisatracurium or rocuronium or some other agent that defeats the purpose. And why to intubate with the same agent? Why not? So it does make sense if you are avoiding muscle relaxants altogether. And there are so many situations, but you still need intubation. And in the beginning, I would suggest always have a muscle relaxant close by, either succinylcholine or whatever you have, just in case you're having some difficulty. I always start remifentanil infusion as a baseline before I decide to intubate. So my technique, I use 4 microgram per kilo, and concentration I prepare for this is 100 mics per cc. So my upper weight limit for any patient is 100 kilogram, even if patient is 150, which I have intubated, but I use the 400 mics as, or 4 cc of this particular solution as my upper limit. Of course, if patient is 75 or 90, then I will go 4 mics per kilo. In that syringe of remifentanil, which I use for intubation, I add 100 microgram of phenylephrine, which will go together as a bolus. And I label it, and I call it jokingly as Remicurium, because to avoid any drug error in your injection of these drugs. So again, reconfirm the concentration and dose for that particular patient. So make sure they are getting the right drug and the right dose. Because it may cause hypotension, NIBP cycling to 2.5 minutes. And I always have ephedrine 10 milligrams in a separate syringe, which I will give before induction. So of course, you pre-oxygenate, keep talking to the patient, then start remifentanil infusion anywhere from 0.1 to 0.15 mics per kilo per minute. You can go to 0.2 as well. Then depending upon the situation, I personally always give midazolam to any patient, maybe from 0.5 to 2 milligrams, depending upon the duration, the dose, duration of procedure, the weight of the patient, and on that. Then depending upon what type of procedure, you add some fentanyl, depending upon whatever you are doing, maybe 50 mics, 25 mics to 250 mics, again, depending upon the surgical procedure. I would just mention that with the remifentanil of that dose, which is a little bit on the higher side, there is something known as narcotic-induced hyperalgesia or opioid-induced hyperalgesia. And so when you stop remifentanil, you wake up the patient. Patient usually start crying in pain, severe pain, once patient is awake. So always have to have some kind of longer-acting opioid as a standard, as a baseline, so that patient does not wake up in pain. So then again, the dose of fentanyl and other drugs will depend upon the type of procedure you're doing. Yes, if you're just doing for, say, MRI and you have to intubate, then of course I would avoid fentanyl. And I give 10 milligrams of ephedrine before induction, and of course lidocaine. After that, propofol will be full dose, depending upon the patient's age, weight, and what you are doing. So just the induction dose of propofol. Immediately after that, I inject Remicurium or remifentanil with phenylephrine. I don't even check the eyelash reflex, because I know that if this causes paralysis or apnea, patient will also be unconscious. I flush the syringe with say 2 or 3 cc so that I'm sure the drug is in the circulation. Then I start the timer. And if it is not a rapid sequence induction, we can perform bag mask ventilation during that period. But I intubate at 30 seconds, exactly at 30 seconds. I ask the trainee or myself to do laryngoscopy and intubate. And if you're unable to intubate or a trainee is unable to intubate, you can have a second attempt or third attempt. But the beauty of this is it is such a rapidly acting drug. If you're not able to intubate or bag mask in about 2 minutes, even shorter than succinylcholine, patient would start breathing and the effect would be disappearing. So I use it as a rapid sequence induction as well. And basically, I'm replacing succinylcholine. What are the pitfalls? Of course, when you do laryngoscopy, you see the vocal cords are not fully widely open. Again, because this is not a muscle relaxant, this causes apnea and relaxation of jaw muscles and other things. But sometimes vocal cords are not fully open. And I have asked, and I have been actually asking whenever I have somebody, some trainee, medical students, junior residents, and anesthesia assistants can intubate. But I suggest them to use video laryngoscopy so that I can see what they are doing. And since we have only 2 or 3 attempts, after that, patient will start coughing or breathing. So we have very limited time frame. So which I inform and warn my trainees before that. It was only this past Friday, day before yesterday, I was in ENT doing some nasal surgeries, and I had 5 cases, and I have a first-year resident, and he did all the intubations with remifentanil with this technique. What commonest side effect I have seen is cough and hiccups while as soon as the tube goes in. And I have seen that in about 10 to 15% of the cases. And I was a little concerned and bothered about that because I don't want any patient to cough. Of course, there was no postoperative sore throat of that sort, but I wanted to make it as smooth. This cough or hiccups usually last about 5 seconds or so. Once the tube is in, cough is inflated, and you start your vapors, so it disappears very quickly. But even then, I wanted to stop that. So since 2018, I have started cheating, and I have added just rocuronium, 5 to 10 milligrams bolus before induction, just like a pre-chloralizing dose. And if patient is 75 kilos and above, I probably give 10 milligrams. So, but the last 5 cases I did on Friday, 3 of them were with rocuronium and 2 of them without rocuronium. And fortunately, there was no cough or hiccup. So this is my setup. So starting from the left, right, and the same sequence will be there. So of course, initially you attach your monitors, blood pressure, NIBP or arterial line, then you have your pulse oximeter, ECG, and put an oxygen mask on the patient and start Remi infusion. And after that, this is midazolam. So this was a 95 kilo patient, but the surgery was only for 30 minutes. So I gave 0.5 milligram of midazolam, then about 100 mics of fentanyl. And after that, in 2 cc of ephedrine, that was 10 milligrams of ephedrine, I have added 1 cc or 10 milligrams of rocuronium, and that I inject. And I always inform the patient, you might feel a little weak or a little drowsy. So don't worry, we are there. So just keep taking nice deep breaths. After that, lidocaine, and after that, propofol, again, depending upon the weight and the procedure you are doing. And immediately after propofol is done, this is my Remi curium. So this is 4 cc of Remi, and that is 400 mics, and 1 cc of phenylephrine. And I just put a sticker of curium, so it is Remi curium. And then same syringe, I flush the line with 2 or 3 cc's to make sure the drug is in. I start the timer, and after that, I do laryngoscopy. So again, to recapitulate, so before 2 minutes before induction, I give midazolam. If you are planning to, this is not necessary, but I would suggest that. And again, fentanyl, depending upon the procedure, from 50 mics to 250 mics for some painful procedure, but that is up to you. You don't have to give it. Then I would give ephedrine. At the same time, I will add some rocuronium at that time and keep talking to the patient. And 1 minute before induction, so this was 2 minutes before, then I will give lidocaine. I usually give between 80 to 100 milligrams of lidocaine to prevent the pain of propofol injection. And after that, I will inject propofol over 10 seconds or so quickly. And once that is done, without checking the eyelash reflex, I would inject remifentanil 4 mics per kilo, and that syringe would also contain a little bit of phenylephrine. Then I start the timer, and at 30 seconds, I do laryngoscopy. At this stage, I will start the timer. And so from November 2012, when this whole thing started, I started intubating patients, and over a period of say 10 cases or 5 cases, I came to this recipe, which I just mentioned to you. I have been doing it about 50 to 60 intubations per year. So not every patient is for that. So patients are not guinea pigs. We use only when we think that it is suitable, and you just want to avoid giving succinylcholine. And there are some contraindications or side effects of succinylcholine we all know, and where you want to intubate rapidly and give an agent which is short acting. So I have done more than 500 cases. So what types of procedures? 75% in my experience have been catheter-based cardiac procedures, like EP lab for ventricular tachycardia ablation, or pulmonary vein ablation for atrial fibrillation, or device closures like ASD closure or PFO closure or left atrial appendage closure. That has been my practice of about 2/3 of my cases. Of course, remaining 25%, which again is significant out if you take it 500 cases. So I've been using it for neurosurgery, for example, burr holes, VP shunts, and simple neurosurgical procedures, or even in prone position where you have to intubate and LMA would not suffice. Maxillofacial surgeries and dental procedures. I was on this Friday in ENT doing 5 nasal procedures of different kind, where you need to secure the airway. I personally feel more comfortable securing and intubating patients who are coming for ENT, but I know some of my colleagues are happy with throwing an laryngeal mask airway. I am particularly a little paranoid and concerned. Same thing with plastic surgery, urology procedures, orthopedics, and general surgery. I would suggest that general surgery and orthopedics, since especially general surgery, if it is laparotomy or something, since surgeons would require some muscle relaxation, and you would use some muscle relaxation for maintenance, so then why not use that same drug for intubation also? But however, certain situations like major burns, or patient has got some neurocognitive disorder, for example, myasthenia gravis, or any muscular dystrophy, or patient with hemiplegia, paraplegia. So there are situations where you would like to avoid any kind of muscle relaxant, and this particular thing fits the bill, my sequence. So I've used it even for laparoscopic procedures, but I inform the surgeons the reason that we should avoid muscle relaxant for whatever reason, and that is why, and they understand and they try to kind of compromise. So my cases have been from age 16 because I don't do pediatric procedures, and I think JD is going to speak about and the pediatric population up to 90 plus years. I think 95 was my eldest patient who came for fracture hip. He was a demented patient. Spinal was not possible. My resident tried a couple of times, failed, so we decided to do. It was a hip fracture. Anyway, from ASA 1 to 4E patients, I have used it. So far, I have not used in 5E, but 5E patients usually are already intubated and coming from ICU or CSRU. As low as ejection fraction of 20% with cardiomyopathy coming for some cardiac procedure or some other procedure, I have used it. I've used it in patients with BMI over 45, and I have also used it in patients who are anticipated difficult intubation. Interestingly, one case which I was doing for redo pulmonary vein ablation, a patient had come for the procedure 6 months ago, and I looked at the notes, and my colleague was unable to intubate in 3 attempts. And so they had to then convert it to just laryngeal mask and proceed with the surgery. So what I used was I had a true pillow underneath just to have proper position, which we do for any anticipated difficult airway. And then I used my technique, and my anesthesia assistant actually intubated with first attempt. Of course, we had the video laryngoscopy. So that is about my personal experience and practical aspects of this wonderful drug. And I'll be happy to answer any questions now or later on. Thank you very much.
Hi, Dr. Achal. I mean, I'm not saying that I've used quite a lot of these for just intubation in patients like those neuro cases, spine cases where there is neuromonitoring, which Nitin as team will discuss, but also for patients who have had allergy to muscle relaxants, known allergy to muscle relaxants. I tend to use TCI because we got TCI mode on our pumps. So we start with 3 nanogram per ml, leave it for around 5 minutes. So as soon as the monitoring goes, drip goes, patient is given oxygen through nasal specs. And then once the patient, everybody is ready, by then I think it's almost 5 minutes, which is usually required. And then I tend to use just 2 to 3 microgram per kg as a bolus, along with propofol over 30 seconds or so. And most of the time we are able to actually intubate without much. Yes, a little bit of coughing might happen, but that is expected and so on. But most of the patients tend to tolerate the tube very easily because of the continuous infusion going on.
You're absolutely correct. Yes, as long as the infusion is going on, the tube tolerance and ventilation is no issue, no problem whatsoever.
Yeah.
And the coughing, yes, as you mentioned, so I wanted to avoid that. That is why I sometimes add rocuronium, but that is not a must. I have intubated more than 100 patients without any muscle relaxant, just with Remi infusion, propofol, followed by Remi bolus. Yeah.
And on the propofol, we tend to use, I tend to actually start, again, these are again TCI pumps. So we use 2 TCI pumps and start them with around 1.5 to 2 microgram per ml plasma concentration on that. And I think with these 2 combinations, I think it is a very, very smooth sailing for most patients. The whole thing can be maintained. And the other thing we have to actually remember is to use the BIS monitoring or some amount of the PEEG processed EEG monitoring for these patients.
Absolutely, yeah. We always use BIS monitor. We have the PSI.
Yeah.
And another thing which I love about remifentanil is emergence from anesthesia.
Yeah.
When I was using desflurane 6 months before or so, that would be my favorite thing, desflurane and Remi. I keep those things till the dressing is done, till procedure is totally 100% completed. Do a suction, gentle suction, put an oral airway, then stop both. And with guarantee, I can tell within 5 to 7 minutes, patient would be just waking up eyes on your command, open the mouth. When you ask them to open, you just pull out the tube. So that is a wonderful thing for emergence as well.
I didn't actually, I think I did touch upon it about stopping or continuing in the post-operative period. Yeah. You can continue remifentanil into the post-operative period. We can actually extubate the trachea with remifentanil on board. And then you can actually look at, so you need to give, like you talked about hyperalgesia or, to be frank, I think because the effect of the remifentanil wears off so quickly, you need to start giving long-acting muscle relaxants, long-acting opioids much earlier on. Otherwise, you'll have patients waking up in that. But the best thing is to actually continue at a very low dose of remifentanil infusion into the post-operative period and wean them off that. And then you get a very, very smooth, one thing, you get a smooth extubation, but also you get a patient who is a lot more comfortable.
Yeah.
Any questions from or anything to add from the other faculty members or team? I don't see any questions being asked because it's something very new to a lot of people. So I don't think you're going to get a lot of questions. And now I think once people start using remifentanil in India, they will. Anybody else want to add anything to Dr. Achal's presentation?
No, I like the observation Dr. Achal's mentioned about the little cough that happens as they tolerate the laryngoscopy so well And and then as soon as the tube goes in, they make a little cough, and then you're like, then you're rushing to give some more propofol or something like that. So if you really, really want to avoid it, that's maybe the challenge. And I think Dr. Achal has given you a little recipe that you can avoid if you're worried about that portion.
That cough does tell you that you're in the trachea. So you're sure, even if you don't get an entire zero, you know that patient is actually trachea is intubated.
And the second thing is, I always when you're using for intubation on this, especially this high dose, you don't use it as a first agent because of the rapidity of onset and the feeling of chest tightness could be very, very disturbing. So never always, post hypnotic agent, whether you used as a bit of midazolam or after propofol, not as a first agent when you're using this high dose for intubation. Yeah, that's good.
Absolutely. I think either you have your propofol running or you actually, I think the easiest way to do is give in adults 2 milligram of midazolam. Do that. I think also you reduce the dose of remifentanil required if you're using that. Like I said, I actually tend to use 2 mic, even though the paper which Achal quoted where they're using 4 microgram per kg bolus, I tend to actually use half of that, 2 microgram kg. And in most cases, because these are adult and you're not too worried about a little cough, it's okay. But in most patients, you don't actually see that.
Can I add something, Dr. Shiv?
Yes, please, Nitin.
Yeah, so I think JD made a very nice point that, when you start Remi, using Remi, there's a common way of doing anesthesia in India that you start with an opioid and then give your propofol and then give a relaxant and intubate. But I think that's the other way around when you use Remi, because if you start with Remi, you will face chest wall rigidity and you'll fail to ventilate and you'll find it very difficult to ventilate. So that's a key practical point, that you induce with propofol and then start your Remi. So we use TCI pumps for propofol and Remi, and it's always the propofol that goes on first and then the Remi. So that's a common mistake that residents do, and then they fail to ventilate, and then that's a difficulty that they face. The second thing I wanted to add was like in ENT procedures, in thyroid surgeries and in parotid surgeries where they use the facial nerve monitoring. And because the incision is very quick here and you don't get time to give a relaxant and wait for it to wear off, so you can directly go with propofol and Remi and very good intubating conditions. We generally do it that way. We run propofol and Remi TCI infusions, and we intubate only with propofol Remi and then continue. It gives very good intubating conditions, and without muscle relaxant, you can easily ventilate these patients and do away with not getting muscle relaxants for the neuromonitor.
Yeah, you're absolutely right. I have actually a patient for parathyroidectomy this week coming up, and that's what I use for these patients. These are renal patients. So these are patients who have got tertiary hyperparathyroidism coming for parathyroidectomy, and that's why I use propofol or remifentanil. But one thing I also do is actually give them blocks as well. And because of the blocks and multimodal analgesia, I don't actually have to worry about post-op giving them longer acting. And so the wake up is actually amazing, because the analgesia is covered by the blocks and just by simple analgesic in that. But if you actually don't have that kind of, we can't give blocks or you can't do anything, you need to actually be sure of in the post-operative period, give something. I think which is actually going to be another thing which people need to learn about, that it's either you continue the infusion or give something as that. Shall we move on? Kadir, are you there? Hi, Kadir.
Good morning. Sorry, I was on call. I was not able to join in time.
No. It's not a worry. You're on time actually. I've already actually given an introduction at the very beginning to all the faculty today. So I think you can go straight on to your talk. You can give your own brief introduction, but over to you, Kadir.
Yeah, thank you. So I go to share here. Share screen.
Yep, you should have the option to share. Yep. It's visible and you're very clear.
Okay, excellent. Thank you, Sue and Global Anesthesia Society for inviting me to this forum on remifentanil. I'm just going to, talk about just cardiac anesthesia. Rather, this is not a lecture. This is more of a presentation of our work, what we have done at University of Pittsburgh with remifentanil. There are some unexplored questions on remifentanil in cardiac anesthesia, and we try to answer them. And it's really not possible to do large-scale studies, which requires a lot of money if you want to answer questions. But we got some financial support from the institution, and we tried to answer some questions. So I'm going to start this. I work as cardiac anesthesiologist at UPMC, which is University of Pittsburgh Medical Center. So if you look at the highest evidence in literature, this is randomized, prospective, blinded clinical trials. Those are all goes up in the order of highest evidence. We try to do that with remifentanil. When you talk about cardiac surgery, there is always a question of what happens when you go on bypass. So cardiopulmonary bypass initiates a lot of stress response, non-pulsatile flow. It's a lot of inflammatory response because it's not a natural kind of anesthesia or surgery. So there is always a question whether these stress response or inflammatory response is natural. Do you need to do anything about it, or do you need to prevent it or let it go? So this is always a question in everybody's mind. It's definitely not answered by clinical trials, whether this is going to be of any consequence. Hyperglycemia of cardiac surgery occurs during cardiopulmonary bypass. You have a non-diabetic patient, put them on cardiopulmonary bypass. Definitely there will be hyperglycemia during bypass. Whether you are a diabetic, you are going to get more and more. So that's related to cardiopulmonary bypass leading to increased epinephrine, cortisol, and other hormones, causing insulin resistance and impaired glucose tolerance. So this can be used as a surrogate for how much stress response the patient is going to get. So we designed a clinical trial, which is prospective, randomized. When you say highest evidence, you have to have a double-blinded. But in this trial, we are not able to do a double-blinded trial. So we did an open-label trial. I will tell you why we could not do it, and a comparative clinical trial. Patients underwent adults 18 to 90-year-old elective cardiac surgery with cardiopulmonary bypass. There are several cardiac surgery which can be done without cardiopulmonary bypass. We didn't include them in this study. The duration, we did it in 2016. So this is just a picture of a group, control group and out of control group in stress response. Study groups of intraoperative in remifentanil infusion group. The second group is a regular anesthesia, which we give every day. It's an intermittent fentanyl group. Every institution vary what they do, but when we surveyed most of the United States institutions, what they do for cardiac anesthesia, they do boluses of fentanyl whenever needed. So give 250 at incision, 250 at cannulation, 250 at emergence. So they do fentanyl intermittently. So that's a kind of standard of practice. So we decided to compare the standard of practice to something which I think will work better for the patients. So those are all the two groups. So the two groups differed in the intervention. What we did, pre-bypass, the typical cardiac anesthesia, we controlled very well in this study what we are doing in this study. So when the patient comes to holding area, everybody gets a spinal morphine. So that's what they get, 0.2 to 0.3 milligrams spinal morphine. They give a little bit of midazolam to sedate and give them spinal. And the patient comes to the operating room, first under local anesthesia with some midazolam, 1 or 2 milligrams. We also give some ketamine, 25 to 50 milligram. The tolerance to the A-line placement is better with midazolam ketamine. So we use that combination to take out the anxiety and put the arterial line in. So before arterial line, we never give any narcotics, because if you give a combination of narcotics and benzodiazepines, they can be harmful in hemodynamically compromised cardiac surgical patients. So we start remifentanil infusion as soon as the arterial line is in. So the dose of starting varied between individuals. Some of the patients who have 10% EF, 20% EF, we start with them 0.05. But the common dose we start is 0.1, 0.2, 0.3, 0.4. And then titrated to, since we have an arterial line, we can always titrate to pressure and then continue this. So we start this at the post A-line placement and then continue till bypass in that dose. Once you go on bypass in this study, we converted the remifentanil to a very high dose, that is 0.5 to 1 microgram per kilo per minute. So we always started with the highest dose, that is 1 microgram per kilo per minute, and then gradually brought that dose down to 0.5 if the patient could not tolerate the hemodynamics, like the patient is on high dose of levophed on bypass because of vasoplegia, then you decrease the remifentanil to decrease the dose of levophed required for anesthesia. So once you come off bypass, again, there are so many things happening, hypovolemia, the cardiac dysfunction. So we decrease the remifentanil and the stress response is expected to be less. So we decrease the dose again to pre-bypass dose. Then we stop the remifentanil at the chest closure. We did not continue into the post-operative period. So this is just an intra-operative study of remifentanil. What happened in the other group? So we gave some intermittent fentanyl boluses during induction, during incision, during sternotomy, during cannulation, on CPB, rewarming, post-cardiopulmonary bypass. We give several doses of fentanyl, 250 or 550 to 250 microgram boluses as required. So that's not standardized because that's the standard of practice. So because one group receives intermittent boluses, which is the standard of practice, the other group receives infusion, we could not just really double blind this study. The sample size, we studied around 116 patients. The excluded around 8 patients, completed study in 106 patients. Remifentanil was given to 54 patients. Fentanyl was given to 52 patients. No patient in remifentanil group received fentanyl. No patient in fentanyl group received remifentanil. So the primary outcome, what we looked for is intraoperative glucose control. We looked for peak and mean glucose values. We also looked at insulin requirement. We had a standardized protocol for insulin administration. Any value above 180 milligram per DL is given insulin infusion. That's the threshold to start insulin. So there is quite a bit of a controversy at what level you will start insulin. But we used a threshold of 180 as recommended by Society for Thoracic Surgeons. So we looked at several secondary outcomes like postoperative glucose control, hormone response, cortisol, ACTH, growth hormone, glucagon. We also looked at inflammatory response like IL-1B, IL-6, tumor necrosis factor alpha. We looked at postoperative pain, narcotic requirement, postoperative nausea, vomiting, organ morbidity, respiratory complication, renal complication, CNS complication, length of stay, hospital stay, and 30-day mortality. So this is the study results. So we looked at the demographics, patient's age, what is the pre-op diabetic control, what is the hemoglobin A1C, left ventricular ejection fraction, what is the procedures done, majority, cardiopulmonary bypass duration, surgical duration. Nothing clinically different. These are all randomly selected patients, no difference between the two groups. So, but intraoperative glucose values, these are all mean glucose values in two groups. So you can see the baseline arterial line blood gas is not different between the two groups. At 1 hour starting the infusions and fentanyl, there is really no difference. This is every hour blood glucose we did. So as the surgery progressed, that means the patient goes on bypass and more stress response. The fentanyl group saw a spike in glucose levels. It tried to 147, 172, 179, 180, 177. But the remifentanil group remained within 150 and 160, 134, 149. The peak glucose level we got here, our mean is 159. Every p-values statistically significant during bypass. And at 7 hours, that's almost near the end of study, the fentanyl group or remifentanil group had similar values. So what we can infer from this is remifentanil significantly as a surrogate of glucose levels, if you think it's a stress response, significantly suppressed the glucose response to cardiopulmonary bypass. So we also looked at insulin requirements. So the total intra-op regular insulin given was 8.1 unit in a median and range in no remifentanil group. But in remifentanil group, it's only 2.9 units. So again, statistically significant. We looked at how many measurements are more than 180 in each group. You can look at fentanyl group had 63.5% patients who had at least one value or two values more than 180 milligram per DL. But in remifentanil group, it's only 27.8% had higher glucose values. So we went to serum cortisol. We sent blood samples during A-line, cardiopulmonary bypass within 30 minutes, before the end of cardiopulmonary bypass, before surgery and post-op. You can see the remifentanil significantly suppressed the cortisol levels compared to fentanyl group intermittent. But as you see, when it reaches the post-operative, it again almost equalized. So when you are running infusion, cortisol level is significantly suppressed. This is ACTH. You can see again suppression of that ACTH response. As the study ends, it again goes up. Growth hormone again showed the same trend till the CPB end and again rise into comparative values in both groups. Glucagon did not show any significant difference between the two groups. So again, hormonal response is also suppressed significantly by using remifentanil infusion. We looked at the mortality at 30 days and readmission. You can see the fentanyl group had a higher mortality and the higher readmission rate. Again, the p-value was significant. So these are all good things of running remifentanil infusion compared to fentanyl boluses. So what did not come as significant? Post-operative blood glucose levels. Since we stopped the infusion during the intraoperative period, did not continue into the post-operative period, you can see the post-operative blood glucose levels are not significantly different between the two groups at all. Again, the measurements more than 180 is also not different between the two groups. Inflammatory markers. The remifentanil can do to glucose stress response, but if you look at the inflammation, it did not make any difference between the two groups. So you can see the IL-6 same, IL-1B same, tumor necrosis alpha same. So this is totally a disconnection between a stress response. There is a lot of theories going on in the literature saying that, okay, stress response is suppressed and the inflammatory response is also suppressed. That's really not found to be true. It's totally two different factors. You can manipulate a stress response, but you may not be able to manipulate inflammatory response with anesthetic medications like remifentanil. So we looked at postoperative complications also, sepsis, cerebrovascular accident, prolonged ventilation, pneumonia, renal failure, AFib, postoperative rhythm problems, multi-system failure, postoperative ejection fraction, length of stay. Nothing significantly came out different except that mortality and readmissions, which I have shown. No difference between the two groups at all. So you can suppress stress response, but unless you, probably what we hypothesize, unless you affect the inflammatory response, the postoperative outcomes are not going to be really different. That's one conclusion we can make. So remifentanil effectively suppressed hormonal response to cardiopulmonary bypass. Glycemic intraoperative response was effectively blunted by intraoperative remifentanil infusion with decreased intraoperative insulin requirements. Remifentanil decreased 30-day readmission and mortality, which need to be further explored. The sample size of 52 and 54 is really not enough to conclude this is a real effect. Intraoperative stress hormone suppression did not have a significant influence on postoperative blood glucose levels. So we may think if you suppress the cardiopulmonary bypass glucose levels, the postoperative glucose levels also will get better. That's really not found to be true. Remifentanil really uncouples hormonal and inflammatory responses. One is suppressed, another is not suppressed. So this study we published in British Journal of Anesthesia, but we extended that study to long term. So anesthesiologists are always fascinated by studying what modifications you can do perioperatively to affect the long-term outcomes. Though I have to say not many studies, not many strategies worked out to affect long-term outcomes. This is something blamed on remifentanil. Like if you run remifentanil, patients with hyperalgesia, patients are going to get chronic pain, so stay away from it. So that's a kind of concept. This is ideal study to look at these patients long-term because we run almost like 1 microgram per kilo per minute, which is extremely high dose compared to commonly used dose. We could do it because we can run it during bypass. We can control the blood pressure with flows in the bypass pump. We can run some vasopressors. So we could do that. You can't do that in non-cardiac surgery. But non-cardiac surgery stress response may be less than cardiac surgery stress response. So this is an ideal study where we can follow up these patients and see whether there is a hyperalgesia or chronic pain. So we did that. So as you follow up patients, some of these patients will fall out. They may not, they could not be contacted. So we could follow up on 43 patients in this group and 42 patients in this remifentanil group. Chronic pain assessment could be done in 43 and 38 patients. These are all secondary outcomes. So let's look at acute pain. Is the remifentanil intraoperative infusion really affected acute pain or not? Postoperative analgesic narcotic requirement is not different between remifentanil and fentanyl group. Number of patients who received IV fentanyl analgesia for sedation is around 15% here, 13% here. All other patients received hydromorphine. Most of these patients received hydromorphine, oxycodone. We converted all these doses into oral morphine equivalents. But when you convert fentanyl, it becomes a very high proportion. So we presented it separately. Acetaminophen, same dose between the two groups. Ketorolac, quite similar, not different. Gabapentin, again, some minority of patients received. We looked at static hyperalgesia. They have something called von Frey hairs, and then you touch around the incision and you look for exaggerated response. We looked at preoperative baseline, 48 hours and 96 hours. Again, not really different. So the remifentanil really did not increase the hyperwound, hyperalgesia compared to fentanyl. It could be a common factor for all narcotics, but that may be a little bit going too much. To separate the anesthetic medications from what happens during surgery is really not clear. So hyperalgesia in these two groups, not really different. So these are all the pain scores between remifentanil and fentanyl. You can see the remifentanil had a score of 8.2 over hours. It decreased. A same parallel response with fentanyl. Those are all the maximum pain scores. This is a scale which is, truncated 8.8. So the difference is not really that much. Again, the remifentanil NRS scores, this is the average scores, not really different. There is a kind of 1 point difference, but I won't say that's clinically very significant. So chronic pain, we followed up these patients. The first category is any pain. So if the patient complains of pain, we noted as pain incidence, positive. Then we looked for who had severe pain, more than 4 NRS. So we followed these patients for 1 month, 3 months, 6 months, and 1 year. So you can see these patients have a significant pain at the end of 3 months and 6 months. 1/3 of patients had significant pain at 6 months after cardiac surgery. Not significant pain, some pain. And then it continued till 1 year in quite a bit of patients. But there is no difference between these two groups, whether it is there because of the surgery, whether you give fentanyl or remifentanil, it did not make any difference. Again, we followed up severe pain. Severe pain is less compared to any pain. Obviously, you can see 80% of patients had some pain, 47% has severe pain at 1 month. It's not really, we are kind of ignorant of what is happening to the patient after we discharge. The patients continue to complain of pain. You can say 50% of them have severe pain at the end of 1 month after surgery. 3 months after surgery, 1/3 of patients. So again, the difference between remifentanil and fentanyl group is not significantly different. So we kind of concluded that whether you give remifentanil or fentanyl, the patients, there is no increased hyperalgesia, there is no increased chronic pain just because of remifentanil. And it's just remifentanil took unnecessary blame. It's any narcotic can do that. So that's up to my talk. The two things I also want to mention in recent days, remifentanil is expensive. We don't use it for every patient. This is for study. We have done it. It's impossible to use for every patient, even in United States. We do not have target controlled infusions, just like Shiv was talking about. That's a better method of giving anesthesia, cardiac anesthesia, especially because you can feed back to the blood pressure, BIS, and all these things. So that will be a better form of giving anesthesia. Number 3, in this study, obviously, we haven't continued the remifentanil into the post-operative period at all. So is there a way we can run a remifentanil, at least a low dose infusion in the post-operative period, and see whether it makes a change in stress response and then outcomes? It's not clear. It needs to be studied. But to involve ICU, to increase the cost of the drug infusion, at that point, when we are starting the study, I thought it will be easier just to do an intraoperative study. Again, you manipulate the intraoperative hemodynamics, intraoperative stress response, and you don't care about post-operative period. The patient outcome is unlikely to change. So any care we do, excellent care we do in the intraoperative period has to be continued till whatever the time it is. It varies between patients. You may have a patient whose stress response may last for 7 days. You need to continue measures which suppresses stress response for that period to make a difference in real outcome of the patients. And number 3, the percutaneous procedures are gaining a lot of traction in the cardiac area. Remifentanil is a great drug for those procedures, like TAVR, the aortic valve replacement percutaneous. In some patients, I use remifentanil infusion. There are a lot of competition for remifentanil nowadays. People use dexmedetomidine, people use propofol, people nowadays use remizolum, which is another drug in the market. But remifentanil is unique. It, as Jardi mentioned, prevent coughing if you use appropriately. And then number 4 is there are a lot of cardiac surgical patients we monitor intraoperative neuromonitoring, like EEG, SSCP, motor evoked potential, like descending thoracic aneurysms. We put a stent in. We want to know whether the motor column is preserved when they put the stent in. We use remifentanil is a fantastic drug for those purpose. Patient, it's almost like a muscle paralysis. If you give a good dose, you can use propofol along with it, or anesthetic gas along with it. But the remifentanil should be a common theme to prevent immobility. You cannot have a patient moving during this procedure where the surgeon put precisely the graft into the aorta. So those patients are extremely useful. Those 2 conditions, we still use selectively remifentanil. So I will say there are still questions unanswered. What is the role of stress response? How do we tackle this inflammatory response to surgery? Is narcotics an answer as a short-acting narcotic an answer? If we run post-operatively, can we make a difference? We do not know, but this is just a start. I think we have a long way to go. Thank you.
Hi, Kathir. I think very interesting, I think, study. Few points I actually was surprised. Well, one thing is the dosing you used in your cases. Don't you think that is actually pretty high on the side? Because if you look and convert your microgram per kg per minute into the nanogram per minute, because we use PCI, that would actually come on the higher side of what is usually recommended. But then I think it has got a ceiling effect on the heart rate, blood pressure. So you don't actually probably see the effects of that.
Yeah, Shishu, I think you are correct. We used a very high dose so that when we review the paper, people don't comment that you didn't use enough dose. You know what I mean? That question always comes up. But you are correct. There is a dose response study, and then the effect on stress response is required. Maybe the lower doses are effective by itself. 0.2 may be effective by itself. I don't know, but I don't want to blame. I don't want the reviewers to blame it on the dose. So I used the highest dose. And what I thought was the cardiopulmonary bypass time is the height of stress response. So we use the kind of pulse dose to just affect that stress response, and we were successful with that dose. And then there was marginally increased vasopressor response in that group compared to the fentanyl group, which is expected. But you are correct. I think lower doses may be as effective as higher doses. And when you consider the cost of this medication, you want to use the lowest dose possible.
The other thing was that we know for sure that opioids are not actually anti-inflammatory in any sense. So I was not surprised that you didn't see any changes in the inflammatory markers with these things. Has your group tried to look at other things like, for example, lignocaine infusion? Lignocaine is considered to be inflammatory, plus also help in the pain side of it. One. The other thing, do you use any anti-inflammatories at all? Do these patients get dexamethasone, or do they get non-steroidals, or do you avoid them altogether?
Yeah, so those are all excellent questions. First of all, number one, there is a huge rise in ERAS protocols, isn't it? So we don't use high dose narcotics anymore in cardiac anesthesia.
Yeah.
It's supplemented by multiple drugs like ketamine infusions, dexmedetomidine infusions, and lidocaine infusions. Those are all commonly used in clinical practice. So when you use narcotic primary anesthesia versus non-narcotic primary anesthesia, so you can don't need to do a spinal morphine. You can do a paravertebral block for cardiac surgery, or erector spinae block, or something like that. So if you classify two groups, primarily narcotic group, primarily non-narcotic group, to study the stress response and inflammatory response and what are the outcomes, whether they differ, that has never been done. People started promoting these drugs without seeing any effect on outcomes. Yes, it produces equivalent analgesia to narcotics. Ultimately, you use a combination of drugs. It takes care of the pain, it takes care of the patients, but is it really changing the response of this, stress and all these things and outcomes? We don't know, and that has never been studied. That's a good study to do. Number two, you asked about dexamethasone. In cardiac surgery, there was a study published with almost like 1,000 patients. I don't know the X and X. They used dexamethasone in one group and the other group no dexamethasone, randomized, double-blind kind of study, and it did not. It's a very well conducted study from Europe. It did not show any difference in outcomes. The pain may be different. Dexamethasone is pain as a part of multimodal protocol, but total outcomes hasn't changed by using a steroid and suppress inflammation during cardiopulmonary bypass. Did not change outcomes. The fourth question you asked was.
I also forgot.
So I think there are a lot of work which is not done, but to blame, I think anesthesiologists have the habit of blaming ourselves for long-term outcomes. Don't you think? I mean, somebody like Jardy's group, pediatric group, blamed anesthesia on brain damage, and there is really nothing. There is really nothing came out of it. So the whole purpose of this, I'm open about it, because we blame ourselves on trying to find a solution because it pumps a lot of money into the system, simply. You know what I mean? Instead, I think as anesthesiologists, we have to focus on how we can take care of patients perioperatively better, rather than looking at, there is a study, the famous study published, spinal versus general anesthesia in hip surgeries. And then they looked
even in cardiopulmonectomy, the GA trial.
So, you are looking at mobility at 6 months after hip surgery, and you are comparing spinal versus general. What are the things you expect? I know the results before starting the study, isn't it? So I think there is a focus change required, and we have to focus on what we do best.
Recently, there was actually one, this is from the Canadian group. In one group, they gave Peng block and they didn't do anything. And they said, oh, Peng block, the patients were better. I said, yes, they would be. It's like giving somebody morphine and other not giving morphine, and then saying, yes, they had better pain response. It's no brainer. They got really upset with me.
Well, when we talk, I think I remembered your question. You asked about non-steroidal anti-inflammatory
Yes,
drugs.
that's right. Yeah.
So
I
we
think that
use
was along with dexamethasone. Yeah.
Yeah, so the surgeons are always worried about bleeding in cardiac surgery, so they're very careful in not giving this. Though we know it is controversial.
Yeah.
They don't increase bleeding, but heart surgery, their outcomes are very monitored very closely.
Monitored. Yeah.
It's publicly reported. So when they re-explore these patients, they don't want to take any chance.
Absolutely.
So they restrict ketorolac. We still push for it. If somebody is having pain, we call them and ask them, hey, bleeding is under control. You're okay to give some ketorolac. They allow us to give. That's why you saw in my group, hardly 10-20% of patients received ketorolac. So it's very less. It's hard to study, but there is a big study published on ketorolac use, and it did not change anything. It did not increase the adverse events. So that's what I think.
Nitin has, I think, got his hand raised.
Yeah, a very nice lecture, Dr. Subramaniam. I think in the neuro also, we are very worried about the stress response, especially in cases like SAH, aneurysm ruptures, where patients have this multi-systemic stress condition going on everywhere, and intraoperative remifentanil kind of usage has been shown in literature in the neuro papers that it improves survival of patients by decreasing the stress response, decreasing hyperglycemia, decreasing the cortisol, and so in the neuro we are pretty sure that remifentanil and its good usage intraoperatively and maintaining the stress responses can definitely help it. I wanted to ask you one question, Dr. Subramaniam. So when you use remifentanil in cardiac patients who are very frail, who have a low cardiac reserve, because I've seen people using TCI Remi on such patients who come for non-cardiac surgery, and then these are very difficult because there is a sudden hypotension. So how do you manage these cases with? Do you use Remi at all in these kind of low cardiac output, low EF, frail patients?
Yeah, so yes, the answer is yes. The remifentanil is a great drug for every purpose. So because you can manipulate the drug quickly and then change the hemodynamics quickly. Unless you bolus remifentanil, you are not able to take it back. But remifentanil, you change 0.1 to 0.05. You are taking it back immediately. So I think it's a great drug for even frail patients. As I mentioned, the TAVR procedures, the percutaneous aortic valve replacements, that option is given to patients who cannot be operated, like by open surgeries. And those patients come to the OR very frail, all kind of comorbidities. We can use remifentanil in those patients. It's again, so you cannot just, you have to keep doing it every day. It's a kind of art of giving remifentanil to these frail patients. How much dose you start? I have started at 0.02, 0.04, very extremely low doses, and then climb up and tell the surgeons to just wait, go and have a cup of coffee and come to stabilize the dose range before giving it to them. So if just because the surgeons are rushing and you are in the operating room trying to increase the dose to maximum and then give that will not work with frail patients. So you have to be, take your time and establish a dose, what works for that particular patient, and then provide anesthesia. Yes, it is a great drug even for frail patients. Hypotension can be a problem, and the vasopressor should be readily available. Sometimes I start them prophylactically, a small dose of Levophed, like 0.02. I don't think it is a problem at all. So I think the answer is you have to keep practicing, and then you can master the art of how you do remifentanil anesthesia. It's not like a regular narcotic anesthesia. You do practice neuro. That's how it works. Yeah.
Jordy,
I've seen people who have used Remi, who've started using Remi, and then they have a set protocol for all the Remi cases. They just set the TCI at 3 and then bolus, and that's when you get into trouble. So I think you should go in these frail patients, you should go very slow, and that's the key. And people who are going to start off using Remi in India, they should keep a close watch on this. Dr. Achal, I think your comments also on these kind of cardiac frail patients. If you use Remi, what are your tricks? Do you also use any, like in our institute, there's a protocol as whenever we use a Remi infusion for a proper TIVA, we always have a phenylephrine bag connected, and it's always on flow so that you can immediately push some phenylephrine. So I saw in your lecture that you all
Mix.
you make a pre-mixture of phenylephrine. That's a very smart trick. Your comments on frail low cardiac output patients. Do you still use Remi?
I will let JD say his comments because he raised.
No, sir, you should go ahead because that's more connected.
Yeah, it's cardiac, so you can.
Okay. Yeah, I totally agree with what Kathir. So Kathir, first of all, congratulations for this excellent study and excellent presentation. It was great.
Thank you.
And so just come to Kathir's presentation first. If you recall, we used to rely on high-dose narcotic anesthesia, maybe 20 years back, not very long. The only problem was it decreased the stress response in the form of hemodynamics. But the problem on the other side was we had to ventilate the patient overnight or maybe more than usual. And that led to the so-called balanced anesthesia. So we still use narcotics, but in a limited dose. So I think what Remi in your situation is doing is providing that very high dose narcotic analgesia, which the fentanyl was providing 20 years ago, but with the advantage that it's such a short acting agent that once you stop, you can extubate, so you don't have to electively ventilate this patient. But this was a very interesting and very good study. Thank you. So coming to Nitin's point, yes, what Kathir mentioned, we can use it for any patient. As I mentioned, I have given it in an ejection fraction 20% patient for intubation. And for otherwise, like Kathir mentioned, we use remifentanil for all our TAVIs, transcatheter aortic valve implantation, with ejection fraction very low, so many cardiac and non-cardiac morbidities, very frail patients. But again, we have to be careful. And as cardiac anesthetists, I can tell we can play with the vasomotor tone and with the cardiac side effects. But the bottom line is, as long as you are aware what you are giving and what side effects you can have, so we can use it and we can always take the advantage. As they say, the tides are always in favor of the ablest of navigators. So you can always navigate as long as you know what you are doing, what are the side effects. And that is why I started mixing phenylephrine routinely with our remifentanil infusion. So yes, always have levofed or norepinephrine or phenylephrine and glycopyrrolate plus ephedrine readily available, because you never know which patient you are dealing with. Every patient is unique and responds differently. But thank you. Nice discussion.
Jody.
Hi, Kathir, I just have one question around, because it ties into one of my line in my talk. Does the cardiac pulmonary bypass affect the pharmacokinetics of remifentanil?
So
I was also going to ask this.
Yeah, so that's really an interesting question. There are so many things happen with the hemodilution, with the protein binding and binding into the circuits. There are a lot of phenomenon during cardiopulmonary bypass increase the remifentanil levels. There are several other things decrease the remifentanil level. So, but everything kind of neutralizes each other. But because the drug is bound in the circuits, but the dilution decreases the blood levels. So all these things, what you have to be careful is all these drugs, the pump blood and everything is pumped back into the patient also. So it comes back. So whatever you are putting it in is also coming back when you reperfuse the patients. So not a single phenomenon we can say that it changes things. So, but everything neutralizes each other. So ultimately, you don't see a lot of difference between what happens before and after or during bypass. That's my take on this, because so many complicating things happen during bypass. I can't, as you know, ionization of the drug, protein binding of the drug, dilution into the circuits, binding into the circuits, reperfusion, everything affects blood levels, not a single thing. So which happens, how much affects the levels. So I cannot say you an answer in a particular patient. It is a patient variation. But to say that during bypass, the blood levels become low, so you have to give a higher dose is a wrong thing. That's not really true. So I will give a normal dose.
Okay.
Okay, Jody, I think time to move on to pediatrics then. I think we
Sure.
had a good discussion, I think, here.
Yeah.
So I think move on to pediatrics.
Okay.
So
I'll
over
start
to
to
you.
share
Yeah.
my screen.
Yeah.
So while waiting, I think the spinal, somebody asked, I think Dr. Hemant asked a question on spinal. We use lumbar spinal for cardiac patients. And, the bloody tap, it's very rare. If it happens, we don't cancel cases because it is a small needle. And by the time we heparinize, it will be 1 or 2 hours. So usually it's not a problem. So we give spinal. If there is small blood coming out, we don't really cancel cases. We continue.
All right. Can you see my screen?
Yeah, lots of those black spots.
Oh.
I think you got multiple files open, I think, on your computer. Yeah, there are like 1, 2, 3, 4, 5, 6, 7, 8, 9, really 9 files. Don't worry, we can still see.
Is it still there?
Yeah, all of them are there. Rather, one more appeared.
Okay, I'm going to stop share and start again.
Yeah. Just check if how many files are open on your.
I don't have it.
That's interesting because there were at least 7, 8 or tabs, multiple tabs. Don't worry about it, just go for it. It's okay, just go. There's a big one which has appeared now. Okay, yeah, that's gone. This one, yeah, that is gone as well.
Are you okay?
Yeah, just go for it.
Okay. I'm Elavarjist Srinivasan, one of the staff in Hospital 6 Children in Toronto. And Shiv, thank you for this opportunity to present some of the pediatric specific aspects of using remifentanil. I think Shiv, as well as Dr. Achal and Kathir, have covered a lot of areas already. So this is going to be a quick run on some of the practical aspect of using remifentanil in pediatric patients. Shiv already covered this. So metabolism of remifentanil by tissue and blood esterases and leaves a very little, if at all, any potent agent in the system. There's a bi-exponential decay curve, small volume of distribution and rapid distribution phase, just over a minute, and extremely short elimination half-life. So those are the practical, that also lends to the practical advantage of using these drugs even in the pediatric population. Even in neonates, remifentanil has a rapid clearance and a large volume of distribution, and the half-life doesn't change very much with the age. So you don't need a bolus before starting an infusion. Pediatric patients do require a slightly higher dose. They do tolerate a higher dose compared to adults. And we just clarified with Katia that the pharmacokinetic profiles are unaffected by the cardiac pulmonary bypass, unlike other opioids. And Shiv already mentioned that there is a similar instance of PYNB. There is probably some slightly higher incidence of shivering. And because the rapid elimination of the drug and ongoing analgesia plan is very much required in the post-operative phase and before starting the remifentanil infusion. So coming to the practical aspect, I think Dr. Achal has clearly covered the intubation side of use of remifentanil in adults, and you can extrapolate that similar to the pediatric patient. I would say that our usage of drug is around 2 to 3 mics per kilo dose. As Dr. Achal mentioned, we don't have access to TCI pumps, so we do it manually for as a bolus and a separate syringe. My usage is usually around 2 to 3 mics per kilo. Very often for patients who don't require a continued muscle relaxation, for like example, a dental procedure, ENT like tonsillectomies, foreign body removals, esophagus foreign body removals. Those are the ones where you typically grab a syringe of Remi. Our pharmacy do supply it with the diluted Remi, so they give us like 20 mics per ml, 5 cc syringes. So that's very, very convenient for if you have a list of dental patients. That's you can grab a few of those syringes for that list. Second most popular use, most common use for us is use of total intravenous anesthesia techniques, very often in the context where you want to avoid muscle relaxation, even for intubation, as well as continued avoidance of muscle relaxation in any neurosurgery and spine surgeries. The dose in this population we use is around 100 to 200 mics per kilo per minute of propofol, along with the remifentanil, somewhere between 0.05 up to 0.4 mics per kilo per minute. And you titrate the Remi based on the hemodynamics, as well as and you titrate the propofol based on your BIS monitoring or EEG monitoring. Second group of patients where we are very oftenly use remifentanil propofol combination is patients who cannot have vapor, patients with muscular malignant hyperthermia or Duchenne muscular dystrophy. The third group is in rigid bronchoscopy, where use of vapor can be challenging because of the open nature of the circuit. So I'm going to briefly in the next slide talk about how you can use remifentanil for pediatric rigid bronchoscopy, foreign body removals or laryngoscopy and examination as well. And the other popular group where we use remifentanil for pediatric patients are in maxillofacial surgery, like craniofacial surgeries, where I'm talking about Lafort 1, Lafort 2, 3, as well as in ENT surgeries, cochlear implants, patients undergoing middle ear surgery where you want a bloodless field. Very often we use it as an agent that obtains the hemodynamics better. This is some pediatric literature around the dose of remifentanil for intubation. This has been used for, this has been studied widely. As you can see in this particular paper, they studied at 2 mics or 3 mics before induction of anesthesia with IV propofol. One thing about remifentanil is that it's not going to be as good as a muscle relaxant, so you have to accept some compromise in the laryngoscopic view. It would not be as perfect as you would expect. So you have to choose your patients wisely when you are starting to learn how you're going to use the drug. Don't go for your most difficult patient in the beginning of the case. Like our discussions in the previous talk with how to use it in patients with compromised cardiac function, you have to learn the use of the drug in a healthy population before you extend your practice to some of the challenging situations, whether it's a cardiac patients or patients who may have a little challenging airway. Should we need to give glycopyrrolate for every intubation with a Remi? Probably you don't always need it, but do use it over 30 seconds. But if you're using a high dose, when we say high dose, we are talking about 3 mg per kilo or 4 mg per kilo dose, then you probably need to consider using some glycopyrrolate. And one other thing, especially in pediatrics, you will have patients with trisomy 21 where you're doing a mask induction or sevoflurane induction. These patients do exhibit a significant degree of bradycardia after sevo induction. And then the next thing is that you got an IV in place, and then you give a bolus of Remi for intubation or something, then you will quickly run into bradycardic arrest. So do use glycopyrrolate in those circumstances in patients with very high vagal tone. So this is sort of a setup for a rigid bronchoscopy where you probably, in this particular patient, for example, I got the patient off to sleep with the sevo induction, and then we placed an IV and we started our propofol. Very often in these, because of significant stimulation with a rigid bronch, we start with 250 mics per kilo per minute of propofol and quickly go up to 300 and 350 mics per kilo per minute. It might convert to be a very high dose when you compare to adult population, but children do tolerate very well, and they do continue to spontaneously breathe. We also use remifentanil. We don't give a bolus because here the objective is to maintain a spontaneous ventilation, and the patients are breathing on their own, and you're going to supplement oxygen is some sort of either through the side port of the bronchoscope or as a nasal cannula. The Remi, the starting dose is probably around 0.05 mics per kilo per minute, and you can titrate it to 0.08 or 0.1 as you're observing the chest and looking at the respiratory rate and the depth of the pattern of breathing. The equally alternative techniques from rigid bronchoscopy is, instead of Remi, you can use dexmedetomidine. Then you might wonder what is the difference between these two techniques. So the dexmed in our practice came in, use of dexmed came in only in the last 3-4 years when we started increasing using dexmed for these procedures. Prior to that, very often we would do a remifentanil propofol technique. And when we started using dexmed, and so the populations that do undergo these procedures repeatedly are patients with vocal cord papillomas. And then the parents on entering in the recovery room very often will complain that something has changed. What you have changed, we don't know. My child has been very extremely sleepy for long periods after this procedure. So one of the beauty about remifentanil is that it provides a quick wake up. And parents do notice that if you switch over to a dexmedetomidine technique, the patients are going to be very sleepy afterwards. Nothing wrong with dexmed. It provides a better operating conditions, but you will pay the price in the recovery room. And remifentanil can do something similar operative conditions without having to have a prolonged recovery state. So you can learn the use of this drug and play with it. And learn what works best for your population and in your hands. So hopefully this slide will play. This is one of the kid undergoing a bronchoscopic evaluation of the vocal cords, and this is under remifentanil technique. As you can see that you can provide a very smooth plane where they are spontaneously breathing without coughing and puffing. And this is how the chest looks with this combination of propofol Remi technique. So what are the doses when you learn to use this drug? For spontaneous ventilation, we would typically start with the 0.05 to 0.1 mics per kilo per minute. Beyond 0.1 mic per kilo per minute, very difficult to maintain a spontaneous ventilation. Whereas for controlled ventilation, you would go with 0.1 to 0.4 mics per kilo per minute. Usually you're doing the changes based on the hemodynamics like around 0.05 mics per kilo per minute changes. So you might start with 0.1, you might go into 0.15, and then 0.2, 0.25, 0.3, 0.25, that sort of thing. When you're using in a controlled ventilation, very often you're using propofol. And as the time goes by, based on a BIS, or even if you don't have BIS, you can generally bring the propofol down to 100 mics per kilo per minute. For people, as Dr. Achal mentioned, in Canada, we don't have access to TCI pumps. So for people who had practice or who learned the technique using TCI, if you need to have a conversion, this is what this conversion table would look like. I think Dr. Shiva already covered all these doses and the power and the similar equivalence of nanogram per ml versus mics per kilo per minute. So very often you will find this is where we would be in surgical anesthesia is around 0.2 mics per kilo per minute. Now you'll find in the literature as well, how about mixing propofol and Remi? They call it as PR 2.5 or PR 5, which means that you're mixing 25 mics of remifentanil to 10 cc of 1% propofol. That gives you 2.5 mics per ml of propofol. And you can run this as a spontaneous ventilation technique. You can set your pump for the propofol dosing. That's 200 to 250 mics per kilo per minute. And this can work for your lumbar puncture sedation, upper and lower GI endoscopies with spontaneous ventilation, just nasal prongs, or face mask oxygen. And if you're using for controlled ventilation, you can mix like PR5, which is 5 mics per ml of remifentanil. So you take 50 mics of remifentanil, add to 10 cc of 1% propofol. And if you run this at 200 to 250 mics per kilo per minute, and then over time, you can bring it down to 160 to 180 mics per kilo. This is useful for where you're using either a laryngeal mask airway or endotracheal tube to maintain the anesthetics for more painful procedures like G-tube insertion, biopsies, or any chest tube insertion in pediatric practice. So these combinations have been practically used, though you will find some literature against any mixing of drugs for the reasons of micelle formation and the possibility that it can lead to a higher incidence of allergic reactions. But in practical sense, people have been using this mix for a very long time. Just a word of caution. This I lifted from one of the pediatric textbook where they talk about the doses. And I found the dose, they talk about 0.25 to 3 mics per kilo per minute as a continuous infusion. So this is extremely high dose. We would never use it as this high dose as a continuous infusion. You might start with this dose, but you would probably go down to your 0.25 very quickly within like few minutes. So just be aware when you're copying a technique from a book, and so do talk to people who use the drug and find a way that works for you and what is safe for you. So so they mentioned is 3 mics per kilo per minute. It's probably they're using as a starting dose, but probably within the next few minutes they will be coming down to the typical dose, which is 0.25 to up to 0.3, 0.4 mics per kilo per minute. Just be aware of this. Kathir already touched on this, and he blamed anesthesiologists for problems we are trying to solve. So remifentanil and hyperalgesia. Okay, I'm going to give a few studies here. 2006 study from sick kids. Let me bring out all the 3 studies. Here, the one in the bottom. Development of acute opioid tolerance during infusion of remifentanil. This was in 2006. Sorry, my years are mixed up here. So the bottom one, development of acute opioid tolerance during infusion of remifentanil pediatric scoliosis, they found Remi is not good because it causes hyperalgesia. And within that, and they corroborated that using a study in cellular model as well. That in 2008, they showed that use of remifentanil increases the NMDA response. And that's the reason for the remifentanil-induced hyperalgesia tolerance. But people have been using remifentanil for nearly 20-25 years now without having any clinically significant pain issues in the immediate post-op recovery phase, which is what, again, from sick kids, that's what they found here, association between intraoperative and post-operative opioid consumption. They did not find that any significant challenges with use of remifentanil. And in fact, when they looked at this particular paper, fentanyl versus remifentanil-based TBAF for pediatric scoliosis repair, patients receiving fentanyl intraoperatively showed increased post-operative opioid use and pain scores compared to remifentanil. So, in practice, use of remifentanil doesn't lead to a significant pain issues in the recovery period. So, this hyperalgesia should not deter you from using remifentanil in your practice. All right, that's all I have.
Thank you, Jody. I think that was nice, short and sweet.
I think you guys covered most of the aspects that Dr. Achal covered about the intubation. You covered the pharmacology side of things. I think my take was just to give the snapshot of where it could be practically useful, and then just add in as questions come on.
I like the PR 2.5 and PR 5.
Yeah,
I think I'm going to use it soon.
Yeah, that's a very practical things. I mean, we sick kids are traditionally like a vapor-based institution increasing. I mean, when I say vapor-based, general population, that's what we are CO fluorine. Whereas we are compared against Vancouver and BC Children's, they are total intravenous based practice. When I say we always use TIVA for our neuro cases, spine cases, MH, like muscular dystrophy and all those things. And we have a huge population where we endoscopies and MRIs, these are all intravenous anesthetic techniques. But the general populations, we do use vapor. And in Vancouver, they do use a PR 2.5 and PR5, very commonly they combine. But I know in the UK, there is this discussion around the pharmacokinetic of a drug mixing, and there is a missile formation, and there is some articles from some allergists in the pediatric journals that it can increase the chance of allergic reaction when you mix these two agents. I just want to make sure that people understand that.
Yeah, but I think if these people have been using in children for such a long time, you would have had a huge number of critical incidents.
No, they don't. I mean, it's one of those theoretical things that people have studied in the lab and come up with, but in terms of practical things, we don't. Again, like hyperalgesia has been extensively studied here at sick kids. Like 2006. Yes, it causes problem. We should pre-treat with some morphine. Or my practical way of doing spine surgeries, in fact, I don't give them morphine until we extubate it. But you have a short, sweet window where they're coming off the Remi, you've taken out the tube. Within the next 5 minutes, I'm just bolusing morphine as you go to the recovery room. So I smoothen that phase with fentanyl as well as morphine, so that I have a predictable extubation without any delay after 8-10 hours of spine surgery. So again, it's an art of, as Kathir mentioned, it's an art of learning how you use the drug, and you get good at it over time.
I mean, that's one thing one of my colleagues used to do is actually use combination of fentanyl and morphine. As a patient, he switched off the remifentanil. So quicker onset with fentanyl, and then
yes, exactly.
Morphine. I think that's a known thing. And I think it's mentioned in literature as well. Rather, in adults, they use much bigger doses of fentanyl and morphine in these cases. Okay, any other comments or any questions, Nitin?
Jerry, how small or how young neonates have you used Remi, like in your practice? Because do you use it in neonates? Do you use it in the low birth weight, whatever kids you get for those surgeries?
So by the nature of why they come to the operating room, it limits the chance of you using the drug in an extremely small population or even in neonates. The one group where you can consider using it is when you have a TEF kid, truncoesophageal fistula kids, who needs a bronchoscopic evaluation and spontaneous ventilation technique. You can use Remi, but again, that the higher incidence of apnea, so you might stick with 0.03 or 0.05. Along with the propofol 200 mics per kilo per minute. And then even in that population, it's very difficult to titrate, and by nature, as soon as you institute any anesthetic, they will stop breathing and you need to assess their ventilation. So it's very finicky to use in such a small population. I don't think you gain a lot by using Remi. And even in some of those tricky patients with Dr. Achala was mentioning, Kathir was mentioning about, like cardiac patients, for some of, for me, it's the practical thing is if the airway is good, why I complicate my anesthetic technique using Remi, and I run into problems of bradycardia or hypotension in this population. If I can use rocuronium, I would use rocuronium. Even though the surgery may not need rocuronium, but the patient is complex, I use rocuronium and it can reverse with Sugammadex. So you have to choose wisely, like what is good in your hand, especially in a population which you don't encounter very often. But that's not the population you want to learn how to use the drug.
Very important message. I think it's you need to be very careful in these small neonates. Because I'm asking this because in India we get a lot of these spinal dysraphisms, meningomyelocele, and these are very young, so they would want to be operated. The surgeons want to operate very early. So is there an issue with because they use neuromonitoring in this case, and can you use Remi in these cases? Because it's a big headache to do anesthesia for these kind of neonates in India. I face this because we didn't have Remi and it's only propofol and a mixture of dexmed and propofol, so no inhalationals as well. So this is what I wanted to ask you.
Yes, spinal dystrophy, meningomyelocele, yes, you can definitely use. We do use it for those population. Again, we don't. I mean, the myelomeningocele is disappearing in our practice. That population. I don't know whether they get either. I know there is this intrauterine surgeries that's been offered for some of these populations. They're very heavy, but even or whether they get terminated. I've in our practice, I probably see one every year at the most. So we don't have a huge population, but definitely neonatal neuro-anesthesia surgeries where you're monitoring the motor evok potentials and SSCPs, you can definitely use remifentanil. There's no contraindication, and it works fine. And you should be able to extubate at the end of it. That's not a problem. If the surgery is small and there's no other reasons why the patients need to be intubated, you should be able to extubate at the end of the case. Yes.
This is going to solve a lot of problems for pediatric neuro.
Yes, definitely. Yeah.
Because meningomyelocele and this spinal dysraphisms are quite common in institute. So we do get lots of these cases, and all of them are done under IONM. So this will, it will give an option for the anesthesiologist.
As you mentioned, intraoperative neuromonitoring, that comes to mind is that we typically don't use dexmedetomidine in any patients where we are doing neuromonitoring. Our neurophysiologist will show us typical recordings pre-dexmed and post-dexmed and how the MEPs are suppressed. So this is quite maybe different from institution to institutions. And if I compare our institution neurophysiologist with Toronto Western, which is the other neurocenter, big center in Toronto, they will be happily using dexmed for those populations. Yeah, so there's always this sort of a how.
The idea is with or without dexmed is okay, because you basically get your baseline after you start dexmed or without dexmed. So you get a stable state anesthetic and then get your baseline and then continue monitoring. So the problem in India is, see, we've gone the other way around all over the world, that you got Remi and then started using dexmed. But in India, Remi didn't come till now. So it was basically people started using dexmed to avoid problems, and so people are very used to using dexmed in India. Okay. And now they will get the Remi. So it's the other way around there. So it will make it interesting for people.
Yeah, I'm sorry. I don't know how to raise the hand. I'm sorry for interrupting. Just Chadi and myself kind of agree on many things nowadays, not in my olden days, but so I think I did mix things here in for induction of anesthesia. I mix etomidate and propofol and lidocaine in one syringe and inject for cardiac surgical patients who work best. In terms of infusion, Jadi, I think I'm kind of thinking, when you mix drugs, do you think you lose the ability to independently titrate the drugs compared to a pre-mixed syringe?
Of course, yeah. That's why you can't use that syringe to give a bolus. You will run into problem. Yeah. So you have to, if you so these procedures where you're mixing drugs is, you will still have a separate propofol syringe if you need to give additional boluses. But your Remi is like going to be in the background, and your dosing on the infusion pump is on propofol dosing, but you don't use your pump to give a bolus. Yep. If I'm doing a TIVA for like a rigid bronch, I would set it separately. Where you want independent control of the drug, you should keep it separately. Neuro patients, spine patients, we all do it separate infusions. You don't use that combined. It's combined ones is useful when in short procedures, rather than for as a routine in a longer cases where you want independent control of those indications. I agree with it.
And one question for all of you, if you are practicing in your practice, anyone using remifentanil infusion for post-operative analgesia in ICU or anywhere?
No, not in our practice, definitely not. I mean, sometimes you have this sort of a behaviorally challenged children who may need some sedation as part of their post-op management, or even to getting into the ICU, especially like the typical population I do get worried about is patients with severe obstructive sleep apnea coming for tonsillectomies, Down syndrome kids, or behaviorally challenged kids, where you don't want to give them a lot of opioids because of this airway obstruction, and you would choose dexmedetomidine as a primary sedative to transfer them safely or to recover them safely, rather than using opioid-based sedation in this population. Yeah, no, not as a remifentanil. We do extubate patients on Remi at less than 0.05 mics per kilo per minute. If you're worried about extubation response and smoothened extubation, especially in neuro kids, but outside that, not as a continued infusion into the recovery room or to the ICU.
Agree with JD. In Cleveland Clinic here in Abu Dhabi, we do not transfer patients on remifentanil because of safety issues. I think because when you transfer patients on remifentanil, it becomes very difficult to keep an eye, on the blood pressure, and so it makes it a little bit challenging. So we do not transfer patients, even in the neuro patients, we do not transfer them on remifentanil.
Yeah, same with us, Kathir. I've never seen Remi being used in intensive care, but I got this beautiful clue from JD to use the PR because we transfer our cardiac patients to ICU on propofol infusion because we hardly extubate on table. We did during the peak of not anymore, but our patients are extubated next 2 to 3 hours. During that time, we have some propofol infusion running. So I was just thinking of doing a PR 2.5 or something, and while transfer only. So that is just the thing, but we never used Remi in ICU.
Mukilan?
Yeah, sir. So I think I read in some of the study which showed that the remifentanil infusion is used in intensive care unit for refractory increase in ICP. So who are not controlled with propofol infusions or with osmotic diuretics, they have used remifentanil infusion to decrease the ICP. So I found this in some of the literatures.
That's very interesting. Yeah. Anyway, I mean, we're coming to the neuro session anyway. Yeah, Nitin, you want to? I've already introduced you guys at the beginning of the session, so please go ahead. Over to you, Nitin. Nitin, Mukilan, and Vinay are going to talk about remifentanil and neuro setup.
Okay, so thank you, Dr. Shiv, for this opportunity, and I'd like to thank Mukilan and Dr. Vinay, who work with me in the neuro team in Cleveland Clinic. I'll just start off with a lecture on how remifentanil is useful in neuromonitoring, and then we will have a kind of a panel discussion of how we use remifentanil in our neuroanesthesia practice. So I'll just share my screen. Okay, can you see my slide?
Yes, Nitin, and you're clearly heard.
Okay, so I'll be talking on remifentanil and how it is a game changer. And I would say this, that remifentanil has changed my practice tremendously. In neuroanesthesia, I think there's a perfect marriage between remifentanil and neuroanesthesia, because whatever we desire to have through any anesthetic agent intraoperatively, whether it should be for avoiding muscle relaxants for neuromonitoring, whether to decrease the stress responses and thus decreasing the brain swelling, or to even have a smooth extubation. So remifentanil produces and gives us all this luxury in neuroanesthesia. So my career, I think I would mark as pre-Remi and post-Remi. So things have changed tremendously, and I will surely tell people who are watching from India that people who are doing neuroanesthesia that Remi will change your practice, and you should take the practical points from the lectures from all the panelists, and this is definitely going to be a game changer for you guys. So I have no conflict of interest, and I'm currently working in Cleveland Clinic, Abu Dhabi. So whenever we do intraoperative neuromonitoring, we are always out of comfort zone because you cannot use certain agents, and you need to provide immobility while the neurophysiologist is trying to give stimulus to the motor cortex and the patient is moving. So it makes anesthesia more challenging, and then the agents that we use should not also affect the IONM. So our anesthetic goals are the frequent anesthetic goals that we target are hypnosis, analgesia, immobility, cardiovascular control, and protection. Apart from this, there is an added responsibility that we should facilitate IONM, and also we must understand what IONM modalities are being used and thus titrate our anesthetics so that we don't affect the IONM signals at all. So as such, anesthetics are synaptic inhibitors. So they cause synaptic inhibition and that's how anesthetic act on the brain and various other neural structures. And by IONM, what we are trying to monitor is synaptic transmission. So there is a direct conflict between anesthetics and IONM. So there should be a fine balance between providing optimal anesthesia and also facilitating IONM. So this is a fine balance that needs to be created whenever IONM cases are being done under anesthesia. So the problem is that all the generators of the IONM signals, like the brain, spinal cord, muscles, and also wherever the IONM signals are recorded, are affected by anesthesia. So in a dose-dependent manner, the neurophysiological signals get affected by IONM. So we have to be very careful while providing anesthesia. So the concept of balanced anesthesia that we give for all other anesthetic procedures or all other surgeries. But the problem comes with IONM is that we tend to avoid benzodiazepines because they affect somatosensory evoked potentials. We can use opioids and we can use hypnotic agents, but inhalationals are not preferred because they affect motor evoked potentials. And also paralytics are avoided whenever we use any kind of MEPs or triggered EMG and these kind of IONM modalities. So there is limited options. So we are left out with only two options, that is hypnotic and an opioid. So you have to manage your anesthetic with this. So I would briefly divide anesthesia for neurosurgical cases with IONM into two categories. One is an awake and then one is under general anesthesia. So in an awake craniotomy, whenever you encounter an awake case, so we tend to give scalp blocks, we give local anesthetic infiltration, and also we tend to run background sedation infusions. And most of the places follow this principle of asleep, awake, asleep technique. That is, the patient is first sedated, lines are placed, pins are put, position, skull incision put, craniotomy done. And then once the dura is open, then you want the patient to be awake and also the IONM to be precise then. So in India, most of the awake craniotomies, as I know, are done under propofol and dexmed infusions. But now Remi will provide that other choice that you can titrate your opioid infusion very quickly, and it gives a very good analgesia for awake craniotomies as well. So under general anesthesia, I would say that the general anesthesia IONM is divided into three stages. One is the induction, that is the takeoff, and then there is a maintenance phase, that is the cruise when everything is under steady state. And in this steady state, you acquire your baseline and then keep all the other parameters as normal as possible: temperature, mean arterial pressure, no hypotension, and no anesthetic changes. And then you make any changes in the IONM signal responsible. You give the responsibility on the surgeon and tell him that probably this is a surgical insult. So the maintenance phase is the most important phase, when everything has to be in steady state. And then finally is your recovery stage. So all anesthetics will affect evoked potentials in a dose-dependent manner. So there has to be a fine titration, and they cause a latency delay and an amplitude reduction. The evoked potentials are the effect of different anesthetics on different evoked potentials is different. The visual evoked potentials are the most sensitive to anesthetics. So we generally try to use propofol and remifentanil in visual evoked potentials. Next is the somatosensory and the motor evoked potential, and the brainstem auditory reflexes are the most resistant. So they are not affected by most of the anesthetics, and we can use whatever we choose to. And remifentanil has minimal effect on IONM. So all other anesthetic agents in a dose-dependent manner can cause effect on IONM, but remifentanil is safe and it is not known to cause any effect of IONM. So based on what is being monitored, how we titrate our anesthetics, like when we use any kind of motor evoked potentials or when we use electromyography, here you cannot use muscle relaxant. So you can only use it for intubation. And then how we do it is we use it as we give a muscle relaxant for intubation, and then as the draping and the incision is placed, then we acquire a baseline. And then onwards, we do not repeat muscle relaxant, and we only run hypnotic and opioid infusions. Also, for motor evoked potentials, we cannot give inhalational anesthesia because inhalational anesthetics at higher doses can affect motor evoked potentials. For the somatosensory evoked potentials, you cannot use inhalationals and nitrous oxide, and neuromuscular blockers then do not directly affect somatosensory evoked potentials. But most of the IONM today is a multimodality IONM. So it will be a combination of all these IONM modalities together. So it will be mostly SSEP with MEP with something else. So it will be mostly a hypnotic and an opioid infusion that we can run. So our drug regimen in our institute is that we always do TIVA. We use propofol with remifentanil, and we use a TCI pump. And these are the TCI pumps that we use. This is the Alaris TCI pump that we use in our institute. For propofol, either a Schneider or a Marsh model. And we generally target an effect site concentration of about 3 to 4 micrograms per ml based on processed EEG monitor. We do not use any inhalationals, no nitrous oxide. It's like a zero MAC anesthesia. And for the remifentanil, the Minto model is the most popular one, which we use. And the effect concentration would be around 3 to 4 nanograms per ml. Some anesthetists also add dexmedetomidine to reduce the requirement of propofol, but all this has to be done in the initial phase when the baseline is being acquired. And once the baseline is acquired, we should not change the anesthetic infusions. So TCI pumps, I would say, is very useful to do TIVA. It gives you, it makes your life very easy. So it's like an adaptive cruise control in your car. So you basically set the dose and then keep the TCI will maintain the infusion. It will give a bolus and then it will maintain a steady state infusion. Very beautiful, smooth way of doing anesthetic. Just what we want for IONM and for neuroanesthesia. So this is our remifentanil and propofol TCI, how we use it. We use dedicated pumps for both of them. And then we also use a three-way, which is, it's an IV connector with a less dead space. So there is a direct connection at the patient end to the IV cannula, where we generally use the transparent one for propofol. We use the green one for remifentanil, and this is for the IV fluid. So this reduces the dead space, and also it is color coded. So everyone, practices this in the similar way. So we do not have any confusions. And always, whenever there is a long case and we tend to run remifentanil at high doses, especially in neuroanesthesia, we generally have a dedicated phenylephrine line. In our institute, it's a policy to use phenylephrine in a pharmacy prepared bag. So we get phenylephrine bags, and this is 25 milligrams and 250 ml. So this concentration is what we use, and we use phenylephrine infusions as a background, because generally when you run remifentanil infusions, there will be hypotension, because remifentanil causes intense sympathetic blockade, and you generally tend to have hypotension as well. So it's better to have a phenylephrine infusion connected when you're doing remifentanil infusion TIVA. So the problems are that, though it can give a smooth extubation, but you should be very careful about the rebound pain that can happen. So it's always good to give a long acting agent before you attempt an extubation. So my practice is, whenever they're closing the skin, I generally tend to give a longer acting agent and then come down slowly on my remifentanil while they're removing the pins. And many a times I do extubate on remifentanil as well to give a smooth extubation. The problems, again, hypotension, like I mentioned, and also you should be very careful in patients who are frail, like we already discussed, patients who are having low cardiac reserve. And one point that we tend to forget while using remifentanil is we tend to go at a level and then stick onto that level. So always, I think remifentanil has to be titrated to effect. So, the nociceptive stimulus. So if the stimulus is not very high, then you don't need to use a very high dose of remifentanil and cause unnecessary hypotension. So you should always titrate your remifentanil and look to give as much as required only. Because I've seen people using very high doses of remifentanil, and then there is hypotension associated. So these are all about the evoked potential. So whenever there is a reduction in evoked potential monitoring, we should always have a checklist, look for temperature, look for hypotension, no change in anesthetic bolusing, and then warn the surgeon for any insult. So in India, when remifentanil is going to be coming in, it will change the practice, especially in patients for IONM, because it gives that immobility, it gives that steady state concentration, and it doesn't affect IONM signals. So a very good drug to use, remifentanil, and it is definitely a game changer especially in neuro-anesthesia. So common mistakes, what I normally have seen with remifentanil is that when you set the infusion pumps and set the pumps, so when you're probably in a hurry, you may set a wrong model for a wrong drug. So many a times it has been seen that remifentanil with a Schneider model. So always make sure and double check before you start the infusion that you have the correct model on the correct drug. And one more thing that we already discussed was starting Remi before propofol. So many people start Remi and then give a propofol, and you would find difficulty in ventilating. There'll be a wooden chest. So this is the other way to do it, is to first give the propofol and then start the Remi. And also hypotension and also using long-acting opioids we've already discussed. So always have depth of anesthesia monitors and depth of muscle relaxation monitors along with the TIVA that we generally run. We generally use depth of anesthesia monitors to avoid underdosing, to prevent awareness, and also to prevent overdosing, to cause prevent delirium, postoperative cognitive dysfunction, to prevent hypotension. So BIS or a SEDline or whatever is in your institute, or it's better to have one of these to practice good propofol TIVA. Also, you can do some amount of analgesia monitoring with these monitors. So entropy, the response entropy is one which has an EMG component, and difference between state entropy and response entropy gives you an idea about analgesia. So this will also help you to titrate your remifentanil bolus, infusion, and kind of acts like a depth of analgesia monitor. Another monitor that has recently come up is this Fresenius Cabby one. It's called Conox. So similar to what like entropy or BIS, it gives you a nociceptive and a consciousness number, and this also takes into account the EMG component for analgesia monitoring. So depth of analgesia, I would also I would take this opportunity to say that in the future, I think we should move ahead to monitor also depth of analgesia. This is mainly to prevent underdosing, to prevent tachycardia, hypertension, brain swelling, and movement, and also to prevent overdosing, to unnecessarily not cause hypotension and also cause drug wastage. So I have used a couple of them. This is a pupillometry, which is also called as algae scan. So this basically is like when you're anesthetized patients, you just place it on the pupil and you see the pupillary reflex. And if there is lack of analgesia, there is an intense sympathetic stimulation going on. With the surgical stimulus, there is a pupillary dilatation, and this can be monitored in terms of a number. This is very easy to use, and it has a replaceable eye cup, and you can use this in the practice. And also, this is a heart rate variability monitor which we had in NIMANS when I was in Bangalore. This is an ANI which is also coming up in a big way. This basically uses heart rate variability and looks at the balance between sympathetic and parasympathetic tone, and gives you a balance between nociception and anti-nociception. All this can be used to titrate analgesics in the future. I think in the future we can move ahead to also adding depth of analgesia monitors, though all this is still in the research phase, but this will probably come in the future. Just want to make this tell about this in the lecture so that people know about this as well. So this is the ANI monitor with the sensors attached. Also, this was one other depth of analgesia monitor that I had used. This is called an SPI, which is a GE patent. So this basically looks at the plethysmographic signal, and this basically looks at the pleth amplitude and the pleth interval. So whenever there is a pain stimulus, there is peripheral vasoconstriction. So the plethysmographic amplitude will reduce and the interval will also reduce because the heart rate increases. So this has an algorithm by its own, and this also gives you a number as surgical pleth index. Not going into details of all this, just to orient people about depth of analgesia monitors. This comes with the GE monitor, and many centers in India are using SPI for depth of analgesia monitoring. So remifentanil usage, you can do depth of analgesia monitoring and titrate the effect also. So this was all about the depth of analgesia monitoring. So to conclude, so for IONM, the key features and the golden rule is steady state anesthesia. Remifentanil is a key drug. It does not affect IONM signals, and TCI pumps also help in this steady state infusion, and it makes our job very easy. Thank you. This was about the lecture on IONM, and we have a panel as well. Vinay and Mukilan are with us. So we would just discuss about how we use remifentanil in our practice, and then we can take up questions in the end. So Mukilan, how do you use remifentanil in your neuro-anesthesia practice? How do you start? Practically, if someone has to start remifentanil infusion usage in their neuro-anesthesia practice, what tips would you give them?
So in our institute, we get remifentanil in 2 vials. One is 1 mg vial and another is 2 mg vial. So if I'm going to use a TIVA, so I'm going to use Remi with propofol combination always. So for my Remi dosage will be, I dilute it to 40 ml with a saline, so that comes around 50 mics per ml. So I use it in Minto model. So I do it in a different way. So mostly when I use with propofol with remifentanil, I start remifentanil as the first, because the most of the time the patient complains of pain because of the propofol infusion. So I start Remi at 1 nanogram dosage. Then once the pain goes off, I start the propofol, and then I go accordingly. So definitely I use it with the processed EEG monitoring. So processed EEG monitoring with the Minto model and remifentanil, yeah, that's good actually.
Do you use it in all your cases? Is Remi your go-to opioid for all your neurosurgical cases?
Nitin, you can stop sharing the screen now.
Okay.
So I have been using remifentanil for the past 1 year. So when I came to Cleveland, so I was having more hesitation using the remifentanil. So I read about these theories, the patient, it's causing the wooden chest syndrome. So I was very reluctant to use remifentanil at the beginning. So I was using, like in India, like I used fentanyl for starting, then I used remifentanil for the maintenance. But later I found that remifentanil is far more potent and very easy to use. So most of the neurosurgical cases, I use remifentanil for the induction and also for the maintenance. And even for the extubation, as you said, we use remifentanil at a lower dose while extubating, like 1 nanogram. Like that, we extubate the patient, we assess the neurological status, and then we give the long-acting opiates. So I do use remifentanil for almost all the cases. Yeah, yes.
Dr. Vinay, are you with us? Dr. Vinay, can you hear us? You're muted, yeah.
You can listen to me now?
Yeah, clearly. So Dr. Vinay, how has remifentanil changed your practice before Remi and now with Remi? What do you say? How it has changed your practice, and do you use it in all your cases?
Yeah, like Mukilan said, it's been almost like 5 years now since I'm using remifentanil. Yes, definitely. It has made a significant difference. It has made our life easy, basically, especially when you're using IONM. So I basically use it in all intracranial cases. So depending on the availability of this one, but yeah, sometimes just to not to get into the comfort zone, some spine cases or some VP shunts or Borols, I do use fentanyl. You should not lose that touch. So definitely, when in a long case, intracranial case, and you're using IONM monitoring, it's definitely very makes our life very easy. And yeah, like adding to Mukilan's point, so the recommendation is to use 20 microgram per ml concentration, just to avoid any untoward extra boluses or something. So it's better to use diluted to 20 microgram per ml rather than 50 microgram per ml when you're using remifentanil to avoid any overdosages or inadvertent bolus infusions. So that's it. Otherwise, even I believe I usually start Remi before propofol, actually, like at a very low dose, one nanogram. I set my TCA to 1 nanogram. Just it provides that background, some analgesia, some very mild sedation, so that and also it will help in early induction. By the time you are attaching monitors and you already taken the baseline reading, by the time you keep the mask, pre-oxygenate them. So patients will slowly get, and you can reduce the dose of propofol, induction dose of propofol as well. So I usually start some background infusion of remifentanil, just very low dose, usually around 1 nanogram target concentration. And yeah, so I extubate them on remifentanil 1 to 2, not only neuro, in non-neurological cases as well. So keep remi at lower dose and extubate them with background infusion of remi, and you can just stop them once you are this one. But nowadays I use additives like dexmedetomidine along with the background infusions of very low dose of dexmedetomidine. I found it. I mean, and also studies have proven it has some beneficial effect. Dexmedetomidine itself has so much of cardiac, renal protective effect and central nervous system effect, which needs to be corroborated with large scale studies. But multiple, as of now, the literature, whatever is available, do favor using a low dose of dexmedetomidine just to reduce it. Will
not also along with remifentanil.
Yeah, it will. If not the organ protective effect at all, it will reduce your requirement of propofol and other this one. So yeah, this is how I use for particularly.
Do you use it in aneurysm clipping patients? Do you think it has it makes because they say SH patients are have the the most angry looking brains, and with remifentanil, has it changed your practice to before when you used to see this aneurysm clippings and now with remifentanil the hemodynamic stability, do you think it has changed quite a bit with remifentanil?
I don't think it has changed a very lot on the, especially on the miss. If the patient has a severe SAH, doesn't matter what medications you use, patient has severe SH, the brain will be angry looking, there will be a lot of bleeding. Yeah, definitely the tachycardia component, all those things are slightly better managed with your remifentanil, but ultimately what is its impact on the outcome, we don't know. Yeah, but yeah, when you're usually go by, it's rather propofol which is more beneficial, which is shown to be more beneficial than your remifentanil. Remifentanil is just as an additive. It's the more concentration should be on the propofol. What is its impact on your
you agree,
brain relaxation?
Because you have moved recently to non-remi
Yes.
to remi practice. So do you think that it has made a difference in your practice? I see you're smiling.
Yeah, definitely, sir. So there is some. So the REMI is basically it has the original baseline, the characters of the opioids. So it decreases the cerebral metabolic oxygen rate. It decreases the regional cerebral blood flow velocity, regional cerebral blood flow. So everything is that it decreases the ICP. So it causes a good brain relaxing condition. So yeah, I find Remi is more better than fentanyl, which we used it. So because the main thing is because of the continuous infusion, there is no fluctuation of the hemodynamics. We are happy, surgeon is happy, and the neuro monitoring is going on. So definitely it gives us a free hand. So I find Remi is really has made a lot of change in our neurosurgical practice, neuroanesthesia practice.
Do you still give scalp blocks for neurosurgery cases with Remi now, or it has changed your practice?
No, sir. Actually, we are not giving now. So with Remi, I think the surgical stimulus, the hemodynamic variability, if you have a constant continuous infusion, I don't see any hemodynamic changes during the incision or the pinning time or anything. So I'm not using the scalp block right now. So with the Remi infusion, I can titrate it accordingly. So with the BIS monitors and with the process DEG monitors, I have better hemodynamic control. So I don't use the scalp blocks right now. So apart from the awake craniotomy or something, no scalp blocks for the other thing.
I think in India, without Remi, we used to always give scalp blocks just to cut down the hemodynamic responses to pinning, to incision. But with Remi, all this has been simple. I agree to you that my usage of scalp blocks also has tremendously come down. Do you agree to that, Dr. Vinay?
Yes, even I don't use a scalp block until unless it's very necessary. So no, even I'm happy with Because
Because
anyway, surgeons are going
cases
to.
are very long, and the post-op analgesia, we don't know after hours of surgery that the scalp block will give additive post-operative analgesia or not. But
The surgeons are
yeah.
going to use local infiltration. Our surgeons are using ligno with adrenaline for the local infiltration of the surgical site. So yeah, but I shouldn't discourage other people. If you are using, there's no it's a good practice actually. They should use it, continue using it.
Mokilan, do you use Dexmed now in your practice? Before, was Dexmed being you used to use more Dexmed in your practice in India, and now with Remi, has it come down, or what do you think?
Yes. So we were using dexmedetomidine, particularly in awake craniotomies and even for intracranial procedures. So nowadays, after coming to Cleveland, after the usage of remifentanil, I have decreased the usage of dexmedetomidine. So I wanted to add some other points, like apart from when you compare with the other opioids, the remifentanil, the autoregulative response or the cerebral CO2 reactivity response, the curve, the plateau has been increased. There is a low state thing. And there is a neuroprotective effect of remifentanil when you compare with the fentanyl or morphine, because it doesn't interfere with the cortical cholinergic neurotransmission, so which is responsible for the memory impairment and also the post-operative delirium, which is very low in remifentanil. So definitely it has an edge over the fentanyl or morphine in terms of this neuroprotective effect. So, so these are the best advantages or the advantages of Remi over the fentanyl and the morphine. Yeah.
Do you agree, Dr. Vinay? Any comment on this? Dexmed usage before you used Remi, was it being frequently used in your practice, and now you've come down on that? Because I think we used to use Dexmed to get all the effects that Remi is giving us now, to cut down on the propofol, to not give relaxant and still maintain anesthesia.
No, not really. Means I would say I was doing Dexmed very often.
You're a long time out of India, so I think.
Yeah. So yeah, Dexmed. I mean, I use, like I said, it definitely reduces your dosage of pro. Like I have seen, you can come down to target site even like 1.8, 1.6. Sometimes I'm afraid to go below that dose. So Dexmed infusion, I usually give a bolus of 0.4 microgram per kg adjusted body weight, according to the adjusted body weight, and then start at 0.4 microgram per kg per hour. And then as the procedure goes, if it is like 6-8 hour procedures, I like start slowly titrating down to 0.3, 0.2 and 0.1 and then stop. So I have found that it definitely keeps your hemodynamic much more stable, heart rate and other things. And also your depth is much better maintained, and your requirement of propofol definitely will come down. I've seen the propofol.
So in a normal, in a craniotomy case for a tumor, frontal tumor, for example, what dose would you start for intubation, and then what are your numbers like generally? How would you start, and for the audience, just to get an idea how to do them?
Usually give 0.4 microgram per kg loading dose, but adjusted body weight. Don't give total body weight. It will be too much. So just give adjusted body weight of dexmedetomidine, and then start at 0.4 microgram per kg per hour, and then slowly start maintaining an infusion during the period, and then you can titrate it according to your depth of anesthesia. If there's any burst suppression or anything, you can come down or just play with your propofol and dexmedetomidine.
Okay, what about Remi? How will you dose your Remi from the beginning to the end?
I usually for induction start with target site 4 and then slowly come down. I have seen that in neurosurgical cases, once after the craniotomy and your dura is open, usually 0.1 to 0.15, max 0.2 microgram per kg per minute of infusion, dose of infusion, or a target set of 2.53 nanogram is most probably sufficient to maintain your depth of anesthesia.
Very important. So remifentanil has to be titrated along according to the intensity of this nociceptive stimulus. So once the craniotomy is done, the dura is open and you're on the brain, so your requirements come down because the brain is insensitive to pain. So you can reduce your Remi and not give a very high dose. So you have to titrate your Remi and play around through the case. So you said start with 4, then come down, and then extubation. What numbers would you generally keep to?
Around 1 nanogram.
You will try and you will attempt an extubation.
With this dosage, so you shouldn't switch off your propofol or Remi until the end, until the pins are out and
very important point. Yeah, I think
until you put usually because they're so just around that borderline, so just once after the dressing is placed, I just usually come down. Otherwise, if you start reducing them very early, like during the dura closure, patient will start bucking. So you should wait till the surgery is totally done and you have shifted the patient onto the bed, and then only I start coming down on the RME. I usually stop RME like just after the dressing is done, I just bring it down to 1.
Very important point. So don't reduce the REMI on the pins. You might have a patient moving on the pins and can lead to catastrophic bleeds in the brain. So Mukilan, anything different? How would you manage your typical anesthetic?
I agree with Dr. Vinay. So even Dr. Kadir was mentioning about the percutaneous procedures. So our neuro IR interventional radiology procedures also, we are using remifentanil. So the dosage was similar to as Dr. Vinay said. So it peaks up during the intubation. Once the intubation is done and the patient position is done, we do come down on the REMI of 1 to 1.5 nanogram, or roughly around 0.06 or 0.08 mics per kg per minute. So we use it remifentanil even for this coiling procedures, embolization, because it definitely gives an edge over to like other opioids for better rapid recovery, so we can assess the neurological function of these type of patients. Yeah.
So you mean to say in IR procedures like aneurysm coiling or AVM embolizations, as soon as the access is gained and the major part of the access is gained, then you can tremendously come down on the remifentanil and then also give us extubation with remifentanil. So important point to note, in the IR also, it is very useful. More and more neurointerventional procedures are being carried out. Dr. Vinay, you have done a lot of studies on stroke. So what about remifentanil in thrombectomies, so mechanical thrombectomies?
Yeah, remifentanil has been used for both sedation and general anesthesia as a not as a sole agent, along with your propofol or dexmedetomidine. It's test shown. So very interestingly, yeah, recently we had published a paper also. Probably I'll share. Nitin can share the paper with the group if anybody is interested to read the literature. So the benefit of doubt towards total intravenous anesthesia when you're using like propofol. It's just not remifentanil and propofol or remifentanil. So benefit of doubt favors total intravenous anesthesia, but it needs to be confirmed with large randomized prospective trials. So there are a lot of we know that there are like 6 to 7 randomized trials so far, which have compared general anesthesia with sedation. Unfortunately, all our randomized trials have preferred using total intravenous anesthesia. So at this point, we cannot clearly tell that use propofol remifentanil infusions, but definitely the benefit of doubt favors. Also, the interesting pharmacodynamics of your pharmacodynamic effect of your intravenous anesthetics on, like I said, like Mukilan pointed out, the carbon autoreactivity to this plateau is much better maintained with remifentanil. This all favor this one, but we need to have a large prospective trial to come to any clear conclusion. But as it stands today, I would definitely prefer TIVA over inhalational thrombectomies.
Yeah. Okay. So I think we touched on all the most important practical points. Any take-home messages, like anything that people should be careful about when they use REMI? What anything in your experience? Mukilan, you want to tell something?
So yeah, exactly. So every patient is unique. If you are going to select remifentanil, consider aged persons who are more than 65, or frail patients, hypovolemic patients. So most of the neuro patients or the trauma patients coming with the diuretics already in. So these patients are a bit of hypovolemic. So you have to titrate the dose accordingly. So always expect a hypotension, or while using a large induction dose of remifentanil. So have the backup plans in your mind, and always have a phenylephrine backup infusion, so that you can tackle the hypotension. So yeah, these are the things. It is going to be helpful for the
very nice take-home message.
Future.
Careful about hypotension, and in frail patients, in neurologically very sick patients who also have a low cardiac output, low cardiac reserve. So these kind of patients, you have to be very careful with using them. Anything else, Dr. Vinay, you would like to add?
Yeah, and another, like Nitin pointed out earlier, be careful when you're selecting the appropriate model when you're this can happen. It is I believe it would have happened to everyone while using propofol TIVA TCI models. So yeah, the hypotension and bradycardia can be quite significant when you interchange the models and use instead of propofol model in Schneider or Marsh model, you're using Remy and otherwise. So
I think every one of us have made this mistake at some point, and because if you are in a hurry, when you're putting the model, it's very important to choose the right model. And this has happened very frequently, so we have to be very careful about this. Okay, I think that's it from the neuro section. Dr. Shiv, you are around?
Yeah, very much listening to it intently. I think all lectures were very good, excellent, and I think neuro part of it actually covered things which we hadn't discussed, especially neuromonitoring. We did mention about PEEG monitoring for these cases. Because we're combining propofol and remifentanil can reduce the requirement for propofol itself. Obviously, remifentanil cannot be used for anesthesia. It works at a subcortical level, and that's why I think one of the important things is that you don't get delirium, as you have rightly mentioned. I think Mukulan was talking about it. I think the models, I think the problem is with the pumps you're actually talking about. In those things, it doesn't tell you that, oh, this is Marsh model for propofol, Schneider model for the, again for propofol, and Minto for remifentanil. The one I actually showed in the video today, it's very clear. It'll tell you remifentanil, Minto. So that mistakes is not made, but it's happened with one of my colleagues where he actually had remifentanil and selected the Marsh model, and the patient went into a wooden chest syndrome, and they panicked because the trainee was at the head end, and the trainee couldn't ventilate. He couldn't understand what was going on. So it is a known thing. The wooden chest syndrome is actually a known thing, and people have to be careful with when you use the remifentanil. I think very good points actually. I think we have covered most of the things, and since this is the last part of the session where we're supposed to actually have kind of discussions, is there anything anyone wanted to add? We obviously covered general adult. We have covered sort of neuro, pediatric, cardiac, even for that matter, even a bit of vascular was also covered by Katir. Is there anything anybody wants to add? Anybody doing obstetrics? I think one area we didn't cover was obstetrics, because remifentanil does cross placental barrier. But again, the advantage of remifentanil is that in kids, the respiratory depressant effect is gone within minute. So as long as you see a patient who is the baby is not breathing, you just need to support the ventilation for some times, and the drug get metabolized, and the child will start breathing again. It's also been used as a PCA in labor anesthesia. So that is another area. I don't know whether anybody using it in general population. I've not seen anybody use, because we use morphine or oxynorm, but remifentanil is not one of the drugs which is used for pain management. Jody, you got your hand up, or sorry?
Sure. I just want to mention, I mean, this is tying to Nitin and Mukulin's and Vinay's talk. The bolus, especially for pinning, the head pinning, sometimes you are already in a steady state before the pin goes on. So sometimes you may need to give an extra bolus of remifentanil, and it's very convenient to use a mic per kilo dose. Or in children's undergoing BP stent, when they do the tunneling, it's another stimulus phase where you can again a bolus and opioid just to cover the stimulus part without having a subsequent prolonged effect of the medication. That's one of the additional uses you can consider.
So I think that's a very important take-home message. So the level of remifentanil should always depend on the intensity of the stimulus. So this we forget, and with propofol we set an infusion rate and look at the procedure, and we're happy to continue that through the surgery. But with Remi, we should try to come down or go up as based on the stimulus. So I myself gone lazy sometimes, not looking at the intensity of stimulus. So that is one thing that JD also pointed out very rightly. That should be about.
So our surgeons are very generous to ask us, "Are you ready for pinning?" like that. So
That's
in that
usually
aspect,
true.
so we just
That's
go with the remifentanil before they pin. So yeah, definitely that's a good point, Dr. JD. Yeah.
They're also infiltrating the pin site with lignocaine with adrenaline or bupivacaine with adrenaline, isn't it? Because they do also.
Nowadays they are in a hurry now. They know that with Remi, I would see this with Indian surgeons. So the Indian surgeons always do all this because they know that whatever local they gave and all this will create better operating conditions when they open the dura, because the brain will not be that angry. But now with Remi, they know that you can just ask the anesthetist to give a bolus.
Yeah.
So they just say, "Are you happy for pinning?" And then we have to go open the bolus, and then things are good.
Now I'm surprised that you guys do say that you don't give any scalp blocks and stuff like that.
Because the procedures, the surgeries that we do are generally very long. So they would take about 6 to 8 hours. And then the scalp block, even though we add additives like after clonidine, I've tried dexamethasone, but the effect is not very long. And so in India, I would give it for all patients. It would be my routine practice. But now I would say the intraoperative hemodynamics are not much affected with or without the scalp block, not much difference. So,
No, I was talking about a post-op analgesia, because when you are coming off the remifentanil, then if you actually have a good block, then you don't need to, because I don't actually use longer acting opioids in the cases where I use the give block. And I've never seen any patient waking up with severe pain or post-operatively actually being in pain. So it helps in the recovery phase of it. So you're not worried about that, or you are going to switch off, and then you're going to load the patient with opioids or short-acting, long-acting opioids, and then the effects of that.
Yeah, I totally agree with Dr. Shiv. Probably it's one of the least researched or talked about subject in neurosurgical pain. It's one of the least discussed or least researched also, actually. There are very few literature to there are no recommendations or observations or joint statements, which means which definitely definitely on chronic pain post neuro, there are definitely incidences, not high as post breast surgery or anything like that, post operative chronic pain, but they do happen. I've seen patients coming back with occipital pain, coming for occipital nerve blocks as well. This is an interesting field where you need still a lot more understanding and research. But I say there is no harm in giving blocks. Yeah, you should go ahead and give the blocks. We should go ahead and give.
It doesn't take too long. It's like a block, isn't it?
Give the block. Yeah, if you are in a setup and we should give the blocks. That's an interesting this one. Probably need some pain societies or somewhere some good literature to back it up to such. Probably then people use it in all the cases. Yeah, definitely. Like even though we are not giving blocks, I agree that blocks should be, at least in cases, especially in young patients, in chronic pain patients, or patients who are, you feel that are at high risk for pain with low pain threshold. Such people should be given at least make it a point to give block. I agree with that.
Anything else anybody wants to add?
So is remifentanil coming to India now finally? Like
It's been launched there. I don't know about the cost and stuff about it, but I think The thing is, I don't know, it's going to have great competition from dexmedetomidine, which is actually pretty cheap compared to remifentanil. And most people are used to it.
I don't think remifentanil will be that costly because it's quite cheap here also in UAE. It's not a very costly medication.
No.
I think the 2 milligram vial costs somewhere around, I think 60 dirhams or I think 80 dirhams or something like that.
And considering for a long case how much fentanyl you would use, so I think it's very cost effective in that.
Yeah, if you're using for a long, like 8 hours, 10-hour duration surgery, it's quite cost effective actually in the long run. And you're going to reduce the usage of propofol also on the back of it. So yeah, definitely it will definitely save some costs, means, and also it makes so much easier especially for neurosurgical patients, assessing post-operatively, waking up the patient, and makes the life easy for both neurosurgeon and the neuroanesthetist.
I still remember on the first day when I came to Cleveland, so I was in orientation program. So I went to Dr. Nitin's room. There was it's a long case going on. So he extubated the patient, and when he said, "Can you open the eyes?" the patient opened the eyes like this. So it was like a magic. And he said, "See how I have extubated the patient." Then only I know the magic drug behind it. Yeah. Still, I could remember the day.
No, that is the struggle that we used to face in India, with so it will make life easier for neuroanesthesiologists in India. So I'm sure about it.
Yeah, I tend to extubate patient on remifentanil and then stop remifentanil. Then I put a nasospecs on with high flows. I let the patient breathe, and they wake up like a smooth. Yeah. I think it's a great drug. I think.
I remember some of the days when early in my career, a long time ago, in England, when I was that's where I got introduced to the medication. After all these big commando surgeries, maxillary maxillectomies and radical neck dissections and sort of things, we would have expected 12-hour surgeries, and the patients will be in the ICU for the overnight on the ventilator to wean off. 12 hours later, at the end of surgery, we are extubating the patient and then sending them to ICU to be extubated. Like after 12 hours of these long procedures, you can still, it makes things possible, like extubation safely after the prolonged surgeries without worrying about the effect of prolonged anesthetic.
Especially in neurosurgical cases when you want an early neurological assessment, and every surgeon wants an on-table extubation nowadays. And remifentanil is going to make that very comfortable, because otherwise we would pump so much of fentanyl, and then we'll have to wait a long time for the extubation on the table, and we are not happy with so much of accumulated fentanyl. So these are the challenges that we used to face in India, and now it's different.
I was really happy about Dr. Kadir's data on the amount of remifentanil dosage, and but I couldn't find how much of remifentanil he has used in intraoperatively, because the opioid-induced hyperalgesia is mainly based on the amount of remifentanil that has been used intraoperatively. Yeah. So I don't find much of literatures on these things, but if in India, I think I can expect some good papers coming up in the future.
You must be joking, Mukilan. 20 cases here, 20 cases there. Thesis, they produce a paper. Need to be a big. So if you are looking at data like that, you need a large numbers for looking at it. It has to be kind of a database, long. Yeah, it can't be just randomized.
Now, once it is getting introduced in India, we have a huge population, and the papers will come as soon as possible. I know I can.
Yeah, thesis. Well, next few years, you'll see a lot of theses on remifentanil.
Remifentanil, yeah.
I don't think it gives out a meaningful data. We don't know.
Mukilan, that hyperalgesia has been studied for a long time. It is in both in vitro cell-based research as well as in patients population as well, you will find a small difference in terms of analgesic use in the first few hours after the procedure. But in terms of the practical concern, it's like, oh, my patient had an extra 1 bolus dose of morphine compared to somebody who otherwise would not have. So I think in practical sense, it does not make a big difference. We do a lot of spine surgeries here. We probably do like 150 spines every year, posterior scoliosis, idiopathic or neuromuscular. And all these patients, you would say that commonest regime used is 90% of the time is remifentanil as intra maintenance agents. Some of my colleagues will use sufentanil instead. That's alternative. But in the recovery, and we follow them in the acute pain service, irrespective of the choice of the opioid, either they have significant pain or half the population will have no pain. They can be discharged in day 1, day 2. So but when they looked back and they could not find any correlation between the use of opioid in itself as a cause of this. And in absolute term as well, there was not a big jump in post-op analgesic requirement. So in practical sense, I don't think it is a problem.
Yeah, I think good message, JD, because this opioid, this remifentanil hyperalgesia will also ring in many years whenever people come here. So should not be that worry clinically.
Yeah, so the term used is actually withdrawal hyperalgesia, rather than the reason being that if you are not taking care of analgesia before you switch it off, that's what patient is going to wake up in severe pain. And it's simple with pain. You actually have more pain, you require more analgesia, simple as that. So if you're actually now translating that to hyperalgesia, opioid-induced hyperalgesia, and that is actually wrong because you did not take care of the pain properly beforehand and you switched off the remifentanil, you are going to get hyperalgesia compared to other patients who had usual technique. So it is just a withdrawal hyperalgesia rather than opioid-induced hyperalgesia problem.
And one more thing is we are not monitoring the analgesia actually. So in the future it will go there. I think we are slowly getting there, and more of research on this is. I've used a few of these monitors, but I think in the future we will get there. We'll get to a stage where we can say, okay, like how processed EEG has probably become a standard when we use TIVA. Like maybe in the future we will be able to get somewhere there to avoid all this over and underdosing problems.
Absolutely. I think it was a wonderful session, and I hope people who are going to start using remifentanil, they will find this session very useful. So thank you very much, Jody, Katir, Dr. Achal, Mukilan, Nitin, Vinay. Thank you all. See you all.
Thank you. See you.
Thank you.
Good evening.
Thank you, sir. Thank you for the pleasure for inviting us, sir. Thank you so much.